and corn puff. Mexican. Corn puff.
Hello, hello, hello.
Yeah. Yeah.
Well, let's hope that's set up correctly. Hello, my friends. It's Jill Osborne from the Interstitial Cystitis Network. It is Sunday, April 10th, 2022, and it is time for another live support group meeting. My purpose in doing these meetings is to make you so strong, so knowledgeable, so informed that no one can demean you, insult you, tell you that it's all in your head, because it's not. This is absolutely real, and this is treatable. Here, hold on a sec. I've been getting my folks together this morning. All righty then. Let's see here. I got to do this and then hello, Facebook, Lisa. Caitlin says, do you feel people of IC should do a GI map test, O test, to see if that's causing their bladder pain? Well, I mean, if you have a history of bowel issues, I have no problem with doing more testing because I really don't like guessing. I like facts. And if there's even a remote chance that your symptoms are being caused by something wrong with your bowel, I say go for it, especially if you have irritable bowel syndrome and you have more bowel pain, et cetera, et cetera. Donna says, how much? You know what? I was doing really good today until I went out, I ordered a special brunch for my parents, and as soon as I got in the car, my eyes started burning because allergies outside right now are wicked. They're absolutely wicked. How are you guys doing? Doing okay? Here, give me one sec. I hear something. Hold on. You know, you always have to follow your hunch. You got to follow your intuition. I always think that intuition is kind of like a little angel whispering thing. Pay attention to this. Cindy said, hi, Jill. My primary care doc doesn't think I should work from home anymore. She doesn't think COVID would impact me so much. Is there something that I could send her about COVID, I see? Yeah, honey, we've got a whole website built on it, covidcystitis.org. Going over to covidcystitis.org, you can print out all the research. You can show what COVID does to the bladder with COVID, cystitis, etc. I think I even have a printable downloadable sheet on that. Hold on, let's see. Do I? I do not, but you can just print out all that sort of stuff right there. covidcystitis.org. I mean, if you're worried, hi, Gay. Gay, thank you so much for the 200 stars. Hello, Ann. Hello, Lisa. Hi, Gay. Let's see. Hold on. And there's Cindy. Okay. So, Cindy, if you do go back to work, I don't know what type of work you do. I would absolutely be wearing a mask. Absolutely, 100%. You know, the new COVID variant and the X2 variant or XE variant is pretty rough. More contagious. That's what we keep dealing with, are these more and more aggressive and contagious variants. Lisa says, okay, so wait, hold on a sec. Cindy, you're a social worker. So Cindy, can you wear a mask at work? Lisa says, I just stopped taking Elmeron due to my vision issues. Lisa, why'd you wait so long? So you guys know, I mean, I've been silent about it. I was subpoenaed as an expert witness in the federal Elmeron class action lawsuits. So the first round of taste suits, I think, are happening this month. I don't have more of an update on it. All I can tell you is that it's real and it's happening. And anybody who wants to learn more about it can come on over to our website or go to pentosinidisease.org, which is a website we built on that. We discovered the researchers at the Emory Eye Center were the first to believe that they had discovered a eye disease, retinal disease related to the use of Elmeron. A very, very interesting story. Very, very, very interesting story because they had a group of patients come in with a retinal disease that they simply could not identify. They ruled out all of the genetic eye diseases, any other issues going on. But the one commonality that they had was the use of Elmeron over time. And that has since grown and grown and grown and grown with more information, more research studies. And now there's a pretty clear connection between the use of Elmeron and eye disease, retinal disease in particular. So, and sorry guys, my eyes are watering like mad. Allergies are really bad right now. Lisa says, okay, so it's been a week and you're having excruciating pain since you've stopped. That's so sad. I'm so sorry that that's happening to you, Lisa. Did you just stop cold turkey or did you go down gradually? What did your doctor tell you to do? You've been doing the installations, but it's only giving you relief for less than an hour. So most of the patients, now understand that yes, Elmeron still is the only oral approved medication by the FDA for interstitial cystitis. I think it was approved in 1996. But over time, I mean, certainly at the very beginning, it was quite popular. People were very, very excited that we had an oral medication that could help the bladder. But over time, kind of different things happen. Elmeron is associated with quite a few adverse events, changes in liver enzyme levels, difficulty with bleeding, a little bit of, what else? Of course, the eye disease. There were just, and nausea, just really extreme stomach upset. And so it's challenging when you have a medication that you feel is really helping you, but the side effects are so disturbing. They're interfering with your quality of life, or in the case of the eye issue, that you're now struggling with vision issues. So, most of those patients have switched over to an oral supplement, usually based around chondroitin, that is believed to have a similar coating effect. So, Lisa, have you considered trying the CystoMend, the Bladder Builder, the Bladder Rest, or the CystoProtect? We had a research study 2 years ago that was presented at the European Society for the Study of IC, which found that the active ingredient chondroitin was the most effective at restoring the superficial integrity of the bladder wall. And although that was in the form of an installation, we are making that same assumption with oral medication, which is kind of historically what's happened over the years with lots of things. And so it would be reasonable for you to maybe consider trying one of the supplements that might have a beneficial effect. So again, CystoMend is the strongest formula on the market with respect to the chondroitin bladder coating effect. Bladder Builder is the most dynamic, multifaceted supplement because it has the bladder coating effect combined with some probiotics for the gut, combined with some PEA for pain relief. All right, so Lisa doesn't know about any of the supplements. Well, let me grab them off the wall, and let's just I'll give you a little history of it. So hold on a sec. Let me just do this here real quick. You know it's not a meeting with me if something doesn't fall down, right? And let me grab this. So let me give you kind of the history of supplements in general and how they've been used for IC. And let me, of course, say that this is not me saying this. This is the American Urology Association in their IC guidelines released in 2011, revised in 2014, which encourage patients to try supplements in step 1 before they go to things like Elmeron in step 2, because the supplements have far fewer side effects. So the American Urology Association's treatment plan for interstitial cystitis patients is rated based upon the risk of adverse events. So there's 6 steps. So we don't want you to do cyclosporin or even Botox until you've done the super easy stuff, because there's stuff that you can do. There's a foundation of wellness that you can do, which can dramatically help your bladder and or your pelvic floor. So in step 1 of the AUA guidelines, we have, what do we have? Number 1, water intake. Let's improve your water intake. Number 2, diet management. Seriously, if you're pouring acid on your bladder every day in high quantities, that could easily explain why you're struggling to the degree that you are now. And number 3, they encourage supplements along with muscle relaxation, stuff like that. We can go through that later. So anyway, but so why did the AUA put it in their guidelines? Well, because their top IC doctors in the country actually have quite a long history with supplementation. The first supplement that was ever created is Preleaf. So Preleaf is simply an acid reducer. It's been around for over 30 years now. It's kind of like Tums. It's a simple calcium formula, calcium glycerophosphate, that will reduce the acid in your urine. So if you have to go eat something that could irritate your bladder, you can take a couple of Preleafs beforehand, and that will mediate some of that acid or reduce some of the acid-induced irritation. So like 2 tablets of Preleaf can reduce 95% of the acid, I think, in a cup of coffee, something like that. So Preleaf is number 1, but you have to understand that Preleaf is not directly beneficial to the bladder wall. It's not going to help the bladder wall. It's not a treatment for bladder wall. All it's going to do is prevent your bladder wall from being injured by high levels of acid. Okay, so the first supplement, I actually don't have a bottle of the first aloe supplement. Desert Harvest Aloe was created again probably about 30 years ago, and it was actually 2 sisters who got together. One had IC, one didn't. The one with the IC believed that aloe would help her, and they ended up creating this company called Desert Harvest Aloe, and the rest is history. The 2 sisters eventually had a parting of the ways. They had 2 separate companies. I think one is called IC Aloe, the other one is called Desert Harvest. So aloe has a coating and a soothing effect on the bladder wall. Just like aloe would have a soothing effect on a sunburn, aloe does have a soothing effect potentially on your bladder for some, but certainly not all people. Aloe is known, and I'm sure that there are people in here who have had some stomach upset with aloe. And so if you're one of those patients, it just doesn't work. It just doesn't work for you. That's fine, because I don't put aloe in the same category as any of the chondroitin-based supplements. I think the chondroitin-based supplements are more effective at coating the bladder wall and helping your bladder wall heal over the long run. Okay. If you are interested in trying aloe, there is the one that we use now is called Aloe Path. The reason why we switched to a formula like Aloe Path is because we wanted to increase the beneficial effect of the soothing quality. I mean, aloe is most known for being very soothing, calming and soothing. So what Natural Approach Nutrition did, the company that makes this, is added PEA in it, which is a proven reducer in nerve pain. So for those of you who want to try aloe, I would encourage you to try Aloe Path. I think it's really good. All right. So what was the first chondroitin-based supplement on the market? Cystoprotect. New label. It's had several labels over the years. This is the new label as of about a year ago. Cysto Protect is created by Dr. Theo Harides at Tufts University. And big federally funded IC researcher, very interesting story where he was asked by the state to investigate the safety of various supplements. And as he was doing that research, he kind of went, I wonder if this could actually help an IC patient. So he created his company, Algonaut, and created a few formulas. And the formula that's held up over the years is Cysto Protect. So it's chondroitin for the bladder wall combined with glucosamine and quercetin for the antihistaminic effect in an olive oil base. So I will tell you that Cysto Protect was easily the top supplement on the market for probably 15 years. Very, very, very popular. But unfortunately, it changed hands multiple times. They sold the rights of it off to a company called Alevin. Alevin was bought by Meta. Meta was bought by Mylan, and there have just been a number of supply chain issues and things like that, as well as a cancer warning that they had to address. And so Cysto Protect sadly fell out of favor. So the next supplement that was created by Dr. Gio Espinosa, who runs, I think he still runs the like the holistic urology department at New York University in New York City. He has a fabulous website, drgio.com. He's got a fabulous blog. So he created Cysto Renew. Now, realize that the Cysto Protect formula was easily over 20 years old. And we've certainly learned a lot about IC since then. We've learned that for many of us, it's being driven by nerves, et cetera, et cetera. And so Cysto Renew was kind of the first attempt at a next generation supplement. And what made this unique is it used a little bit of lemon balm, and lemon balm is known for a nerve calming effect. So this was the first one that went beyond just a bladder coating to a nerve calming effect and a bladder wall soothing effect, because it does have a little bit of aloe in it. So this then was the top supplement for a couple of years. But then Natural Approach Nutrition came on, and we were again still kind of looking for, kind of a more robust formula based upon some of the new knowledge of IC. And so Natural Approach Nutrition was a new company about 6-7 years ago, and they convened kind of a panel of experts. I was part of that panel along with several other doctors and other people. And our goal was to try to create a supplement that had more methods of action. We wanted to provide a coating effect for the bladder. We wanted to provide the antihistaminic effect for the bladder wall. But he wanted to also focus on trying to restore a good biome. Oh, remind me, I've got something I've got to show you about that. And also to calm nerves down. So it was kind of a year-long discussion process of trying to create a formula that would really take us to the next level. And the end result of that was Bladder Builder. And so Bladder Builder right now continues to be the top supplement on the market. And the reason why is because it combines the chondroitin for the bladder wall with beneficial probiotics for the bowel, but most importantly, it has an ingredient in it called PEA to reduce pain. This was created in 2019. That was the year the European researchers brought PEA to the United States with their big IC study, which found that it was very successful at reducing pain in IC patients. So anyway, this is really fantastic, but it's a very, very robust formula. It's an aggressive formula. And no matter what supplement you try, we always say you got to start really slow. Really, really slow. One capsule, see how you do. Take it with food. Never take any of these chondroitin-based supplements on an empty stomach. If you feel good with 1 a day, you can then go to, for several days, you can go up to 2 a day. You can go up to 3 a day, 4 a day. But I am not a more is more person. I'm a less is more person. I think it's about finding the lowest effective dose, the dose that works the best for your body. Peter says, do you post these videos on YouTube? Peter, we're broadcasting live on YouTube right now. We're on 2 separate internet streams. So we are on Comcast on Facebook. And then when I look over here, I'm looking at YouTube. YouTube is on AT&T. So you can go over to our YouTube channel right now. So with Bladder Builder, when Bladder Builder came out, pretty much, I'm going to say probably 70% of the patients who used the other supplements immediately came forward and tried this one. And we did our 1-year follow-up study with this, and it was remarkable. It was exactly what we hoped, that by in the first year, 60% of the patients who tried Bladder Builder love it. They're still on it today. They're reporting shorter flares. They're reporting fewer flares. They're reporting less painful flares. That is exactly what we wanted. And in fact, a significant percentage were completely pain-free using the Bladder Builder formula. But for the 40% who didn't like it, who were off of it, we asked why. Number 1, cost. Number 2, potential side effects. And number 3, their doctor wanted them to try something else. So if you flare, for example, when you take a probiotic, and some people do because probiotics have the potential of provoking a histamine reaction, that seems to be the number 1 reason why this might not work for some people. And so if you flare with a probiotic, we would say, let's pass on the Bladder Builder. But if not, this is definitely viable because it has 4 methods of action as compared to 2 methods of action. Okay. Now, but what about this? This is the one thing I kept saying is, now listen, I see patients are really, really sensitive. Sylviane says you just tried to order it. Honey, it's coming in this week. The manufacturing got pushed out about 6 weeks. So we are almost out of it, but we should have it again, 2,000 bottles this week, I think. Okay. So anyway, I kept saying, to the owner of Natural Approach Nutrition that we're sensitive. And we know that. I see subtype 5 central sensitization. A lot of us are sensitive. So what can we do for patients who are uber sensitive, who are afraid to try supplements because you never know if you're going to have a reaction to it? And I'm one of those people. I do not like taking new things. My body is wicked sensitive. And so they came up with this formula called Bladder Rest. So Bladder Rest is a really clean, pristine formula. It doesn't have the probiotics in it. It does not have the PEA in it. What it basically has in it is a chondroitin, arginine, and quercetin, and sodium hyaluronic in an avocado oil base. And the reason why they chose avocado oil rather than olive oil, as in the olive oil found in Cystoprotect, is because it's less heat sensitive. So if you happen to live in a hot area, then something like this would be better. Anything in an olive oil base has the potential of melting and sticking together in the heat, which is why we always tell patients, if you're going to buy any of the supplements and you live in Texas or Florida or Arizona or New Mexico in a super hot area, make sure you get enough in like May to get you through the hot summer. Because I cannot tell you the number of times it has arrived stuck together. If you ever get a supplement, you got to shake it first. And if you can hear individual pills, your capsules, is good. But if you hear one big lump, it's heat compromised and you can't use it. You shouldn't be using it. So anyway, Bladder Rest is kind of that next one. And then I do not have a bottle of Cystomend. Cystomend is the newest formula from Natural Approach Nutrition. And it's just a very, very strong bladder coating effect, really ideal for somebody who needs that extra effect from losing Elmeron. So there's lots and lots of things to try. If you go on over to the IC Network website, we have a store. You can click on the store. And then I've got all these supplement guides. So you can read based upon what you might be dealing with. You could read which supplement might be the most appropriate for that. Look at some of the data on that so that you can make your own decisions. But again, you have to remember that the American Urology Association, they're the ones who say, hey, try the supplements. They don't have the same side effects or risks as oral medications like Elmeron. Because of course, now we know that Elmeron can significantly damage your eyesight. So certainly worth trying perhaps some of the supplements first. So anyway, there is that. Hi, Kelly. Kayleen says, you relieved last night. You're being heard again, and you're seeing your urogynecologist on May 4th for this pelvic straining pain. Bladder install tomorrow. Yeah, baby. 39 days till surgery. Woohoo! You got this. All right, so hold on a sec. You guys, if I ever miss your question, especially on Facebook, don't take it personally. Understand that the questions scroll through fairly quickly, and then Facebook will not let me go back and look at them. So Marilyn said, Bladder Builder's working for her along with the prescription vaginal cream after 20 years of on Elmeron. That's great. I'm glad Bladder Builder's working for you. Deborah, thank you. It's a little weird today. Anyway, it's a little funky. All right. Lisa says, I use pre-leaf, but I also avoid all triggers, especially vinegar. Good strategy. And Lisa takes aloe daily. There you go. Amy says, have you ever done a hydrodistension? Just curious. I used to have the lesions. It helped me a lot. See what Jill says, obviously. So a hydrodistension is a way of looking at the bladder wall more carefully and more closely. Basically, what they do is it's always done in the operating room. It's an outpatient procedure. You should not have it done in a doctor's office without anesthesia. The worst thing you can do to a hollow organ is stretch it. Bladder is a hollow organ. It is going to hurt when they stretch your bladder. You do not want to be awake for this. So this is done as an outpatient procedure. Hydrodistensions are no longer required for a diagnosis of interstitial cystitis. Instead, they are done if the diagnosis is in doubt. They're done if the doctor sincerely cannot figure out what's going on with you, or even more importantly, if you have blood in your urine. If you have a lot of blood in your urine, you certainly want somebody to look at your bladder to try to figure out why your bladder is bleeding, or if it is even your bladder, because for all we know, it could be your kidneys that are bleeding. So, and I don't like guessing. I like facts. My personal approach is if I'm in pain and it's been a couple of months, man, I want them to look. I don't want anybody guessing anymore. I already know what it's like to suffer. Every single one of us in this meeting, we know what it's like to suffer. We know what it's like to be up all night crying in pain. And so I'm very aggressive and assertive with my medical care. If I'm in pain and it doesn't make sense, I always want somebody to look at it. Okay, so how do they do the hydrodistension? Well, obviously you're under anesthesia. They're going to insert a cystoscope in your bladder along with something that will allow fluid to go into your bladder. And they will slowly fill your bladder and stretch it a wee bit. It's called a short pressure, low duration. In the old days, they used to do high pressure, long durations. They used to put a lot of water in there under a lot of pressure for a long period of time and really stretch out the bladder. Well, now we know that's fairly damaging to the bladder and that bladders can rupture. And so the American Urology Association guidelines in, 2011, they were very clear. It should only be a low pressure, short duration hydrodistension. And we're no longer going for the big stretch anymore. We want something that's very calming and soothing. That's not calming and soothing isn't the right word. We want something as least invasive and traumatic as possible. So they're going to use some water. They're going to stretch your bladder, hold it in there for a period of time, maybe 3 minutes, 4 minutes, 9 minutes, whatever. They're going to drain it out. Then they're going to take a look in your bladder. They might fill your bladder up with fluid again. But again, the end result is that they're going to be looking in your bladder. Now, listen, if you have a completely normal bladder, this is exciting. This is exciting. Do not be disappointed. Be happy. If they look at your bladder under a hydrodistension, that they looked at mine 4 years ago, and my bladder is good. There's nothing physically wrong with my bladder. That is important information, because what that then tells us is that your bladder symptoms and your pain are being driven by something outside of your bladder. whether it be fibroids, et cetera, et cetera. So if you have the hydrodistension and they see nothing, power to you, that's great, great news. Now you're going to move on to the next step of looking beyond the bladder. But if they do find, for example, little red dots on the bladder wall, we call these petechial hemorrhaging or glomurulations. In the old days, we thought that was IC. We thought that these red dots that clustered in the bladder was a sign of some sort of bladder wall disease process. Well, it's not, and we now know that the test itself can cause all those little dots. So we're no longer really prioritizing or considering the finding of petechial hemorrhaging glomurulations as important to IC. It's basically been thrown out. But the most important thing that they can find with a hydrodistension is called a Hunner's lesion, a big bloody wound. If they find a lesion, generally what they would do is biopsy it, and they would then treat it at that time. They would inject it with a steroid. They would cauterize it with a laser, or also known as fulguration. We want to try to deal specifically with that lesion. And so it's very important if you are planning on having a hydrodistension and you do your pre-op appointment with your doctor, you're going to say, okay, what are you going to do if you find a lesion? And if they say nothing, you're going to say, why? Why won't you treat it? Because the tragedy here is that it's the untreated Hunner's lesion that is responsible for the great majority of long-term chronic pain in the IC patient population. And so the top tier urology clinics always have a plan. They always have the equipment. They are always ready to treat lesions during a hydrodistension. If your urologist says, no, we're not going to treat it, and you're going to say why, and they might say, well, we just don't think treatment works. But underneath it all, it may be a lack of experience, or that they simply haven't forked out the money to have the equipment to treat it correctly. So I would be very, very, very disappointed if you had a doctor who found Hunner's lesions and didn't treat them, because that's going to be a long-term source of discomfort for you. Hunner's lesions respond beautifully to treatment. You just have to treat them. I think the statistic was 85% of Hunner's lesion patients who get treated correctly, the pain goes away. But if you don't treat it, the pain is going to be long-term and persistent. You're going to be very, very diet limited, et cetera, et cetera. Okay, so that's the hydro. Now, recovering from a Hydroq is interesting. Hydros are outpatient procedures. Generally, you're sent home that day. Usually, you should be sent home with perhaps some antibiotics as well as some pain medication. Not a lot of pain medication, but if they can give you a little bit of Norco for the first 48 to 72 hours, that might be very helpful if your bladder gets really stretched or they do multiple biopsies. If you notice that your symptoms suddenly get much worse 3 to 4 days after you have a hydrodistension, that tells us that you might have picked up a bladder infection from the treatment itself. We call that a nosocomial infection, a hospital-acquired infection. I always think it's important to get a hydrodistension on a Monday, Tuesday, or Wednesday rather than on a Friday, because you have time to call your doctor on that Thursday or on that Friday if you're having any issues. And I think it's also worth saying that, I think it'd be reasonable to ask your doctor, you wouldn't be going on vacation the following week, are you? Because that means that there might not be any coverage if you do have a problem. I would reschedule it for another week when they're back, right? Again, today, just to summarize, today's hydrodistensions are low pressure, short duration. They're not really known for damaging the bladder to any great degree anymore. But if you are sent home with a catheter after a hydrodistension, that does mean that they ruptured your bladder. That does mean that you sustained an injury. And that's much less now. It's rare now because we don't do the high pressure anymore. But I'm sure some of you have come home with a catheter. Dandy Blend Herbal Frappuccino for the win. Actually, it's not a Frappuccino. I didn't blend it. So it's an iced coffee. One of the other things, sometimes you get a false sense of security after a hydrodistension that you might notice that you feel better. And you're thinking, great, I'm better. Well, a hydrodistension is an example of what I call a destructive therapy. It is not a constructive therapy. It does not build a new bladder. It is a destructive therapy. What that means is the way that it works is by killing the nerves that normally give you pain in your symptoms. And so when you stretch the bladder, you break all those nerves in the bladder wall that might be causing some of your symptoms. And so you're like, well, awesome, it really, really worked. And for 3 to 4 months, you're good. And then all of a sudden your symptoms come back. That's because the nerves are regrowing. The nerves will regrow. And sometimes more nerves grow back than you originally had. And so having recurring hydrodistensions is really rare now. It's really very, very few patients who would ever consider, having 2 hydrodistensions a year for the long-term maintenance of their bladder and their IC. Some patients do it, but it's not constructive. Lisa says, I take bromelain and quercetin, corn silk, fish oil, true aloe, preservision, turmeric, curcumin, Eustel, urgocalcif, and sand polysulfate, pentosan polysulfate. Well, Lisa, you look at the preservision, and usually it has vitamin C in it. That could be irritating your bladder. And I'm little and so it sounds like you're having Elmeron bladder instills as compared to taking Elmeron by mouth, which would be a much safer way of taking Elmeron. Amy says, what is the website I mentioned on COVID? It's called covidcystitis.org, covidcystitis.org. Sherry says, I think I've realized what's wrong with me after all these years of being in bed since 2008. I think I had pudendal nerve entrapment. I never really researched it to see what it was. I feel better when sitting up a lot from laying down. I had a bladder lift over 30 years ago. I read that it only lasts 10 to 15 years, but the doctors say my bladder is fine. I have other variables and causes. It's so frustrating not get opinions that match up. But you have an appointment and ultrasound scheduled with a gynecologist tomorrow. So Sherry, it's very, 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 very important that you explain to her that you have discomfort that's based upon your body position. So when usually with pudendal nerve entrapment, it's pain when you sit down that it's relieved by standing up, or pain when you bend over that's relieved by standing up. But sometimes for some patients, lying down flat can trigger it, whereas sitting up feels better. The whole concept of positional pain is important here because that's really pointing us to muscles and bones, and how they impact nerves, and how that will then affect the bladder and or the pelvic pain, especially other symptoms of pudendal nerve entrapment. It might be shooting pain down your leg, although that's sciatica. I mean, that's a different nerve, but that's also an example of muscle squeezing a nerve. You might notice that you have pins and needles or areas of numbness somewhere in your crotch, or you might have persistent genital arousal disorder where you feel this painful arousal sensation. That would be all signs of pudendal nerve entrapment. And so, Sherry, and also your bladder lift. So the fact that you had a bladder lift 30 years ago tells us that your bladder and your pelvic floor was messed up 30 years ago. And I don't remember if you're doing pelvic floor physical therapy or not now, but getting a good look at those muscles and what's happening to those muscles, and having the gynecologist touch the area of the lift and the scar tissue, looking for trigger points, anything at all like that might explain some of your pain. Lisa says, you also have the Axionics implant. Girl, you've been busy, Lisa. Hello, Caroline from England. And Lisa, you have blood in your urine too. Is it visible blood? Or is it a microscopic blood? Caroline, thank you for the 100 stars. Much appreciated. Terry says, thank you for covering the supplements. I was prescribed Myrbetriq the other day. It is causing me issues and not helping. So I'm going back to work on the supplements again. I'm getting An in-office cysto in May. I will keep the hydro in mind. I got that high pressure one when I was younger, right? Kayleen says, I felt like I was punched through the urethra right after my hydro. Okay, well, let me say that again. Kayleen said, I felt like I was punched through my urethra right after my hydro. It's really sore for a couple of days. My urologist gave me oxybutynin for a week to calm my bladder. He only said my bladder was smaller than average. Well, Kayleen, I'm not surprised because, girl, honestly, you're really not a bladder-centric person. I mean, you got the endometriosis and all the other stuff going on. Wouldn't surprise me at all if your bladder is normal. Elena says, hi, Jill. I emailed you a clinical remission using personalized low-dose IV infusions of N-acetylcysteine with minimal toxicities for IC. Have you received that? Very interesting study. Let me just pull it up and I'll read it afterwards. I don't remember. Let me just put this in my... I just have not had time to do my normal amount of research reading. It's been very chaotic. My dad's having oral surgery tomorrow. Life, right? Let's do a stretch. Guys, everybody, just shake it out a little bit. I spent all day yesterday in my yard, and we had visitors. The family came, so stretch it out. If you've done this one, for those of us with neck pain, you know, you do this. Ah, the crunchies in my neck are real when I do that. Hadar says, what is the best treatment for a feeling of fullness of the urine? So Hadar, that sensation of fullness can really come from a couple of different things. I think what you're meaning is pressure. Can you try to describe the fullness a little bit more? Does it feel like your bladder is full even when it's empty? Lisa says, after my hydrodistension, the 2-hour ride home from the hospital was excruciating. We stopped halfway at a hotel to use the facilities, and I didn't think I would get back in the car. Yeah, I'm not surprised, hon. Especially if it was an older hydrodistension like 10 years ago or longer when they were doing the high pressures. Amy says, I actually have recurring hydrodistensions every 5 months. I find they really help, but recovery can be rough. Diana says, is Dandy Blend safe for the kidneys and liver? I would assume so. I don't think it would be on the market if it was known for causing significant toxicities. I think you need to go over to their website, dandyblend.com, and you can copy the ingredients and research them. Jennifer, thank you for the 100 stars. Much, much appreciated. Lisa says, I took Elmeron orally, 300 milligrams a day for 3 years, and now recently stopped taking it a week. Right. Jeannie says, I was supposed to have hyperbaric pressure treatments, but my insurance will cover it because my Hunner's lesions were not caused by radiation or chemo. They won't let me self-pay either. I've been in agony. I can't take it anymore. I was really hoping the hyperbaric chamber would finally heal them. So hyperbaric oxygen therapy is a third alternative therapy for Hunner's lesions. It's just not widely available. It's where divers who get the bends, who they're trying to prevent getting the bends from deep sea diving, they put you in a pressurized chamber that delivers oxygen to your bloodstream, and that oxygen is a great trigger for healing. You went last year to a doctor in Long Island, and he did not want to full grade them because they shrink the bladder, and if I have too many now, it can't be done. I'm going back to him now as every other treatment has not worked. So Jeannie, so it sounds like you're going to see Rob Moldwin. So given the fact that you have long-term persisting Hunner's lesions, it would be reasonable to maybe have a viral test to see if there's any chance your lesions are being caused by viral infection, because if that's the case, they can then treat you with an antiviral, right? Lisa says, the blood is both microscopic and visible, sometimes clots, small clots, and then almost always traces of blood. I'm unhappy about that, Lisa. I'm very unhappy about that. Do we know? So if you're peeing visible blood clots, then you probably have Hunner's lesions. And Elmeron is not a treatment for Hunner's lesions. What's a treatment for Hunner's lesions is cauterizing the lesion to stop the bleeding or injecting it with a steroid. I am very unhappy with that. I mean, literally, if you've got clots in your urine, my immediate question would be to the doctor would be, why am I bleeding? What's bleeding? Mary says, hold on. Mary said, I have had radiofrequency ablation to eliminate my lower back pain caused by spinal stenosis. It works like magic. Why can't they do some kind of ablation for the nerve pain in the bladder urethra? Honey, the reason why is because the nerve, you could accidentally damage the nerves that keep you continent. The last thing they want to do is destroy the nerve that keeps you continent. We don't want you to have total incontinence afterwards. So it doesn't really apply in the same degree. Okay, Marcia says, I did not answer the question by Hydroq. So let me see if I can go back and find it. Oh, okay. So, yeah, no, I did. I needed more information from Hydroq or Hadar. I'm sorry. So there is something that, let's see. Let me describe a typical IC flare, the old flares that I used to have. And let's see if this resonates with your concept of fullness, okay? So you go to bed at 10. And of course, you urinate before you go to bed. You wake up at 11, your bladder feels really full. You go to the bathroom and you pee out maybe a quarter cup of urine. You go back to bed. You wake up 30 minutes later, your bladder feels really, really full. You go to the bathroom, you pee out a teaspoon. You go back to bed. You wake up 15 minutes later, your bladder feels desperately full. You go to the bathroom and you only pee out a drop, and you start straining and pushing and you still only pee out a drop. That is because one of the ways that the bladder tells you that the bladder wall is massively irritated is by giving you what we call a false sense of fullness, where you feel full even if you're empty. And you kind of have, and of course that creates a ripple effect, because literally you've been to the bathroom 4 times in an hour. You feel full. You're doing everything you can to get rid of it. You start straining and straining and straining, which is just going to put you into a terrible pelvic floor situation in addition to your bladder wall situation. So there comes a point, at least for me, once I figured out that false sense of fullness, I had to tell my brain, because by that time I wasn't sleeping. I was up 1 in the morning, 2 in the morning. My bladder was on fire. I felt like I needed to pee every 5 minutes or every 10 minutes. So bed was not working for me. So generally what I would do is go into my family room, turn on and grab a giant heating pad, throw it on my belly, and get myself a big glass of water. And I would just try to ride through this flare by protecting my bladder, calming my muscles, neutralizing my urine if my flare was caused by something I shouldn't have eaten, et cetera, et cetera. So that false sense of fullness, it's a trick in a way. You feel full, but you're really not full. It's really nerves that are irritated. And so is that what you're describing, Hadar? Elena says, thanks for the wonderful support. You previously talked about the microgen test. I'm afraid it is not straightforward with this test as it shows back. Well, honey, it shows bacteria in everybody. The microgen test is so good, it's going to identify good bacteria, bad bacteria, and fungus. So, of course, it's going to show good bacteria. Oh, my nose is running. Allergies are so freaking bad right now. Hold on a second. I got to go spray my nose. Oh. All right. Sorry about that. Donna asked about my knee. I don't wear my brace for my knee, right? I have to wear a knee brace. I'm wearing it because I have a femoral nerve injury on my right side from compressed disc. And if I don't wear it, it's like there's a tight belt over my knee and thigh. And that's from the femoral nerve. And so I'm probably going to have to wear it the rest of my life. We'll see. Getting old is not for the faint of heart. I mean, like, literally. So frustrating. So getting back to Elena, her microgen test shows the Enterococcus, medium load, no other bacteria. One of the few chronic UTI doctors said this is not the bacteria that is causing my symptoms, even though it is on my microgen test. And I would need a year's worth of antibiotics for E. coli. I doubt any doctor can say for sure which bacteria is causative. So many sufferers cause bacteria. So many sufferers chase bacteria found by microgen for many years with antibiotics to no avail. So Elena, you're raising good points. You have to remember that interstitial cystitis is a grab bag diagnosis. What do we mean by that? It means that you have the symptoms of frequency, urgency, pressure, pain in the absence of an obvious cause. And the doctor now has no choice but to diagnose you with interstitial cystitis. But we don't think of interstitial cystitis as a bladder disease anymore. We think of it as a pelvic pain syndrome. Why? Because structures outside of the bladder are now very linked to bladder symptoms, such as if you have a fibroid tumor pushing on your bladder, that could mimic IC completely. If you have varicose veins in your pelvis, known as pelvic congestion syndrome, that can mimic IC. If you have endometriosis, as Kayleen is struggling with, that could certainly trigger all the symptoms of IC. If you have posterior fornix syndrome, that can mimic IC. If you've got pelvic floor dysfunction, that can mimic IC. So every person is an anatomical mystery to be solved. And the AUA, the American Urology Association, really understands that. What they say is if bladder therapies don't work for you, you have to take a step back and revisit the diagnosis. What have we missed? What have we missed? Now, there is a very vocal group of people, and there have been for 30 years now, who say that IC is a result of chronic UTI. The problem is that mainstream researchers simply cannot replicate their data. So it first started with Dr. Paul Fugazato in South Dakota. We all did it back then. We all sent him our urine. We all had Enterococcus and Micrococcus and other random bacteria. I did that. I was part of the people who were desperately looking for answers like you. And I remember we were doing all of our lectures at that time. I've done well over 100 live lectures with the top IC experts in the country, in the world, actually. And I've asked every single one of them what they thought of Dr. Fugazato's theory. Nobody supported that. And in fact, the University of Maryland, who were the first to do extremely in-depth reviews for bacteria simply could not find a persistent bacteria. And we see this consistently. Another paper was published just a couple months ago where they were looking at the bacterial biome in the IC patient in the Hunner's lesion patient as compared to the non-Hunner's lesion patient. And there was absolutely no difference in bacteria. The difference was in viral load. The Hunner's lesion patients have virus in their urine. The rest of us don't have virus in our urine, which is why we now look for viral infection in patients with Hunner's lesion. The fundamental flaw with those people who say that everybody with interstitial cystitis has chronic infection is it's proof positive they've never worked with large groups of patients. That's why we have subtypes now. We are not all the same. For some of you, IC begins in childhood. For others, IC begins after menopause. Are you biologically the same? No, you're not. In fact, we now really look for injury and trauma in kids. Okay, for some of you, IC begins after chemotherapy, while for others, IC begins after having a baby. Are they the same? No. Interstitial cystitis really is a grab bag diagnosis. There's very clear diversity in this patient population. So some of you, the reason why your bladder is sensitive is because your bladder's dry from estrogen atrophy. For others, the reason why your bladder is sensitive is because you've had a long-term chronic muscle dysfunction, muscle injury that's caused ischemia to the bladder. For some of you, you have chemocystitis or radiation cystitis from a previous cancer therapy. Do I believe that there is a population of IC patients with chronic infection? Absolutely. IC subtype 2 bladder wall-driven chronic UTI. But it's not everybody. It's probably a very, very small group of patients, maybe 5%. And the question is, what is the bacteria? What is the infection? Is it bacterial? Is it viral? Or is it fungal? Because that's where we're looking now. That's what our own National Institutes of Health made a remarkable discovery several years ago, that many patients who were flaring with bladder pain had an active fungus in their urine. Why did fungus occur? From the overuse of antibiotics. It's fungal infection that is now well known to drive bladder pain. And that data from 5 years ago was just supported in a brand new study from UCLA, came out 3 to 4 months ago, which not only found the fungus, but when they identified it, it was a super damaging fungus, extremely virulent, extremely damaging to cells. And so again, that's why we like the microgen test, because it's the only test that's going to identify if you have fungal infection. And that's really important to rule out, because a lot of you do have fungal infection. I had fungal infection for a while. Now, Enterococcus faecalis, I can never pronounce the second word. It's Faecalis, faecalis. If you Google it and you go to the National Library of Medicine, which is pubmed.gov, you will see a lot of reports of patients with long-term serious chronic infection from Enterococcus. Enterococcus is not as devious as E. coli, but it can still be a wicked bladder infection. So, and you make an important point here, and that is that you have to remember that your biome changes every day. Your biome changes based upon what you eat. Your biome changes based upon the time of day that the sample is taken, where in the body it's taken. Your biome in your urethra is different than your biome in your bladder, which is different than the biome up by your kidneys, et cetera, et cetera. So it's not uncommon to try to chase infection. And that's where you kind of have to take a step back. I actually interviewed the CEO of Microgen a couple of years ago. And I said, how do we prevent people from chasing infection? And in particular, how do we know when infection is there in the first place, a pathogenic infection that needs to be treated? And because I raised that point with him, I absolutely raised that point with him. And he said, it's a combination of two things. What are your active symptoms? Do your symptoms suggest a pathogenic infection? So do you have frequency, urgency, infection, fever, et cetera, combined with the test results? Because if you have no symptoms, and you come back enterococcus, then that tells us that it's a normal part of your biome. But if you come back with severe symptoms and high enterococcus, that tells us that the enterococcus maybe has now blossomed, is now dominating your biome and causing more damage, right? I mean, there's just a lot about the biome that we're all still learning. I wish that I could go back to school and study all this. Again, I'd love to be on the cutting edge of biome research. I would love it. Listen, microbiology is so fun. Microbiology, where you're looking at a microscope of living bugs, like a Volvox. A Volvox is a spherical little microbe that's fascinating to look at, right? And my senior project when I got my pharmacology degree was the isolation of drug-resistant bacteria throughout UC Santa Barbara and our local cottage hospital. I took samples everywhere. I took samples in gyms, in water fountains, on handrails, and I went to the hospital and took samples throughout the hospital. And I came back and I tested it all to see if I could find antibiotic-resistant infection. I found it in almost every sample. Widespread infection everywhere. I mean, antibiotic-resistant bacteria everywhere. So getting back to Hadar. Hadar says, yes, I have that feeling of fullness of urine 24/7 when it's empty. It's a nervous feeling as part, it's a nervous feeling as part of the mucus. I also have pain in the bladder, but that fullness feeling is the worst. So Hadar, if you were on the phone with me, what I would say to you right now is that tells me that there's something on a daily basis really, really provoking your bladder. And because that's kind of the equivalent of your bladder screaming at you saying, help me, help me, help me. If you're dealing with constant 24/7 fullness, even when your bladder's empty, that is your bladder wall begging for help. Normally, when I see this symptom in patients, and we go back and we look at what they're eating and drinking, that there's often something on a daily basis that is massively provoking their bladder to the point that it's quivering. So I would want to know, number one, are you drinking coffee? Are you drinking green tea, black tea, soda? Are you doing any fruit juice? Like I was working with a gentleman who literally was drinking coffee and lemonade all day, like a couple weeks ago. And his bladder was screaming at him, just like yours is screaming at you. Also, do you take a multivitamin? Sometimes that daily irritant is completely innocuous. You think it's okay. And it's not okay. You think this is perfectly fine. You were able to take that vitamin in your 20s and 30s and 40s, and all of a sudden your 50s, it starts hurting you. Why? Because you have estrogen atrophy now because you're older and that vitamin isn't going to work anymore. So are you following the IC diet, Hadar? Lisa says, you have Hunner's lesions, but thought the hydrodistension would cure it. No, Lisa. Hydrodistensions do not cure Hunner's lesions. Where would you get that idea? No, absolutely not. A lesion is an area of profound inflammation. You got to come on over to our website and read the section on Hunner. I even have I built a website on specifically on Hunner's lesion disease. It's hunnersulcer.org. And you can go read that too, but hydrodistension would never cure a lesion, never. Lisa says you've been doing the installation, but even the installations are not believed to be helpful for Hunner's lesions over the long term, hun. Not even close. Lesions require lesion-specific therapy. That's cauterization, fulguration, laser therapy, steroid injection, or maybe hyperbaric oxygen therapy. John says, can bladder or pelvic pain cause rectal pain? Absolutely. Absolutely. Because all the nerves are joined up at the top. And so we called it the pepperoni pizza algorithm, when the research that came out that showed that if the bowel was irritated, the bladder can become irritated. And if the bladder's irritated, the bowel can become irritated. And in fact, John, in our latest magazine, the latest IC Optimist, which was released about a month ago, we did a whole big article on rectal pain. Because I have, so I'm IC subtype 3 pelvic floor driven, IC subtype 5 central sensitization. Okay, that's my subtype. My bladder wall's healthy. It is not my bladder wall. In my bladder, whatever damage happened to my bladder early on, that's long healed. For me, it's all about tight muscles combined with having this wickedly sensitive central nervous system. So a legacy of that for me is that I have very sensitive skin in and around my rectum. It's kind of like a vulvodynia, only I call it rectodynia, where if there is literally anything touching down there, I feel it. It annoys me. If you're trying to go to bed, let's just say you had a normal bowel movement 6 hours, 8 hours, 10 hours before you go to bed. And obviously your bowel's still working, it's still moving things along. And the purpose of your rectum is to store your bowel movement until you get enough in there to trigger a bowel movement. I feel little tiny amounts, like it makes me crazy. And so there used to be times where I couldn't fall asleep. I just, the nerves down there are so sensitive. And my gastroenterologist said that it was because I have a little tiny hemorrhoid, tiny, like we're talking sunflower seed tiny, like tiny, but it's right on top of a nerve. And if there's anything pushing on that, I'm uncomfortable. So John, if you email me, I will email you our magazine so you can read that article on rectal pain, okay? Judy says, do I know anything about pilocarpine for Sjogren's? Not off the top of my head, although I know I've read about it before. Hold on. I have to refresh my memory here. So pilocarpine is used to treat dryness of the mouth caused by a decrease in the amount of saliva. And the medicine may help you speak without having to sip liquids. Are you having a problem with it, hon? Is it hurting something? So if Judy says her microgen test showed nothing 2 times, that's great. That's great. Then move on. You have to move on to other things. Caroline says, where do you get the microbiologist test, please? You can go to a website called Bladder Health, bladderhealth.org, to learn more about it and order it. Jody said, is there a surefire way to tell if IC is pelvic tension derived? Yes, absolutely, touching it. All you have to do is touch the muscles. If you have a pelvic floor examination, you go to a pelvic floor physical therapist, and during their examination, do an internal exam, and if they can touch a muscle and trigger your pain, there's your diagnosis right there. So Jody says, so let me read her. This is interesting. Her question is there a surefire way to tell if IC is pelvic tension derived? You have no lesions, you have overactive bladder, your bladder wall got red and irritated with their test, was reactive to certain foods, but now when I recently tried coffee and chocolate, you had no reaction, but I certainly get pelvic spasms and also in the glutes, and I have to keep on top of stretching and body work and take muscle relaxers afterwards. My doctor started me on instillations of heparin, which don't seem to have any knowledge of the subtypes. Well, that's common. Really only top tier doctors are doing subtyping. My bladder got all red when they tested it when I had a cystoscopy 6 months ago and was having a much harder time. I guess my question is, do people get to the point of not being food or drink reactive? Yeah, they do. Understand, Jody, I call it the chicken versus the egg dilemma. Which comes first, the chicken or the egg? And for us, it's which comes first, the bladder or the pelvic floor? They're both involved. They cannot not both be involved. They are too interconnected. So for some of you, this all began with a bladder wall trauma, whether it was chemotherapy or drinking way too much coffee or Mountain Dew or whatever, or some sort of other toxic exposure. And so your bladder's been massively irritated by drinking coffee all day or energy drinks all day. So your bladder's screaming, help me, help me, help me. And what happens is your pelvic floor muscles get tight in a guarding reflex. You can't turn that off. That's subconscious. And so our therapeutic priority for that patient is to calm and soothe the bladder. We got to eliminate the irritant, give the bladder wall time to calm down with the hope that, here, hold on a second. The muscles will release after we can get your bladder out of pain. Okay. But that's the smaller group. The bigger group is their symptoms didn't start with a bladder wall injury. Their symptoms started with a muscle injury. Now, you have no clue you have a muscle injury. Let's just say that you're a bike rider, that you love riding your bike with families, or you do more aggressive long bike rides, right? And one day you have frequency urgency. And of course, you associate that symptom with UTI. So you call your doctor and say, hey, I think I have a urinary tract infection. The doctor goes, okay, let's throw some antibiotics at it. You do antibiotics for a week or two. They don't get better. You call your doctor back. I still think I have an infection. The doctor says, all right, come on in, leave a urine sample. We'll test your urine. And they might throw a different antibiotic at you while you're waiting. And, you want to get better. You take the antibiotic, but it doesn't work. So you're back at the doctor's office 2 weeks later, a month later, and you say, doctor, it's still hurting. And the doctor goes, okay, maybe you have overactive bladder. And so they throw overactive bladder medications at you like ditropan or Detrol. You try that for several months. That doesn't work. And you go back to the doctor, and the doctor eventually goes, God, I hate to break it to you. I think you got this incurable bladder disease called interstitial cystitis. Here's a diet. Here's Elmeron. I'll see you in 6 months. Well, number one, they're wrong. And we don't think of it as an incurable disease anymore, but that's kind of the process that patients go to. And of course, you want to get better. You do what they say. You follow the most rigid diet ever. Man, and you want to enjoy coffee again, but you are determined, you want to get better. And you might take all the medications they give you, whether it be the Hydroq, the antihistamine, the long-term antibiotics, whatever. But if you're still flaring, then it's not fixing you. You might feel a little bit better. Your symptoms might have improved a little bit, especially with medications that calm various symptoms down. But if you still have this underlying dysfunction going on where you're having significant flares once a month or once every 2 months, clearly we've missed something. What have we missed? Ischemia. For that patient, they have sustained a muscle injury. So let's talk about, let me get my book here. Hold on. Love this book. Love this book. So let's just say that your symptoms began after falling on your tailbone. Okay. So you have suffered a compression injury, or if you were an ice skater or a gymnast or a football player or a paratrooper, whatever. If you have multiple falls on your pelvis, whether it's on your tailbone, or if you're a bike rider and would jam your crotch on the bar of a bicycle, or if you were a motorcycle rider, what we look for is a series of traumas that eventually create fairly significant dysfunction. So the first thing that happens is, bam, you have a compression injury when you fall. You have compressed tissue. Your muscles have been squeezed. Blood vessels have been squeezed. We know that because they break. And when they break, you get a bruise. So how many times have you gotten a bruise? That's a compression injury. Okay. What you don't understand is that it's also compressed the nerves and the blood vessels supporting the nerves. That's bad because nerves need good blood supply to function normally. When you fall on this and you mess your muscles up, one of the things that happens is a trigger point. This is a trigger point. A trigger point is a muscle knot. You know how if you get a muscle knot in your back, you want somebody to push on it? Because if you push on it, it will resolve and go away. Muscle knots are damaging. You can see what the muscle knot is doing right here to blood vessels. See this? Look at what these muscle knots do. This is not healthy. We have good blood supply here. We have terrible blood supply on the other side of the muscle knot. So you know what we call that? We call that ischemia. And that ischemia, that limitation of blood supply, affects everything. It can affect your vulva, it can affect your prostate, it can affect your bladder, it can affect your rectum. So again, for these patients, our therapeutic priority, they can be on bladder therapies for 30 freaking years and they will never get better. And the reason why they will never get better is because it's not addressing the underlying problem, which is blood supply. Our therapeutic priority for the pelvic floor patient is to restore blood supply. The way that we do that is with pelvic floor physical therapy. Okay? Now, here's the thing. When Chris Payne came out with his subtypes 5 years ago, he was met lukewarmly from some people. Those people who insist that IC is a bladder disease, right? And so he's been a real champion in trying to get doctors to look at your whole body. And I think his subtyping system is fantastic. But something remarkable happened a couple months ago. And that is that researchers at UCLA did their own study on subtypes. And they took it one step further. So remember, in the Chris Payne system, he supports 5 core subtypes: Hunner's lesions, bladder wall driven, pelvic floor driven, pudendal neuralgia, and central sensitization. And he rocks it. That is, in my opinion, the best subtyping system we have. UCLA did this very, very advanced computer analysis of patient records. And in their first go round, they were able to identify 3 clear subtypes: bladder wall driven, which in the pain system is Hunner's lesions and bladder wall driven. Number 2, pelvic floor driven. And number 3, they called it NUP, non-urological pelvic pain. So in the UCLA system, these 3 groups, they all had all the symptoms of interstitial cystitis: frequency, urgency, pressure, pain. Okay, every single patient had been diagnosed with interstitial cystitis. But in their sub-analysis, they were able to define a bladder-centric group, a pelvic floor group, and there were a group of patients who had frequency, urgency, pressure, pain. They had more urethral pain, and they had pain, vaginal introitus pain at the entry of the vagina. They called that group non-urologic pelvic pain, or NUP. I was just talking to Denise Pecht about this, Dr. Denise Pecht in Atlanta on Friday about this, because we were so excited about this. All right, so step 1 is they created a system very, very similar to Chris Payne's. The only thing it left out was overlapping pain conditions, pretty much. But the next thing that UCLA did is they looked at treatment success. And guess what? The only patients who responded to bladder therapies were the bladder wall patients. Hunner's lesion patients pelvic floor patients did not respond at all to bladder therapies. NUP patients with this urethral pain and this vaginal introitus pain, did not respond to bladder therapies. And in fact, that was the group that was the most treatment resistant. We all now have to try to understand that NUP group: frequency, urgency, pressure, pain, urethral pain, vaginal introitus pain. What the hell is that? Could be endometriosis. That was one thought right off the top of my head was when I read it was, okay, does that mean that we've got some endo going on? So the UCLA study confirmed the pain system, but it's more broader than the pain. They haven't buckled down and gotten into the details like pain did. But the most important concept is that pelvic floor patients did not respond or get better or would never get better with bladder therapies. So again, in the AUA guidelines, if you're not responding to bladder therapies and you've been doing bladder therapies for 5, 10, 15, 20, 30 years, for God's sake, stop what you're doing, take a step back and revisit the diagnosis and go back to when your symptoms began. That's like rule number one in my office is I don't want to hear what you've done. I want to hear what happened when your symptoms began. How old were you when they began? Can you remember any trauma when they began? Do you have any history of trauma? Did you ever break your tailbone? Did you have a difficult delivery? Were you a bike rider? We have to try to understand the anatomy first. Now, many of you have underlying muscle injuries, muscle traumas that need to be corrected. And, when Chris Payne put out his system, I mean, he was raging. It's like, it's so unfair to tell patients they have an incurable bladder disease. It's not incurable in many of you. It is curable if you have a muscle-driven issue or something outside of the bladder. So this is great. We've come so far. We're doing so much better at finding the right therapies for that patient and getting to the point where they have real, genuine symptom relief, and ideally they're healed or cured. Marilla says, I haven't had severe flare in almost 10 years. The past 2 weeks, I've had back pain and pain in my bladder and legs are hurting like crazy. The only thing I've done different is I started using collagen drinks. That could be the cause. Yeah, girl, you got to look at the... here, hold on a sec. Let's look it up. Is that how you spell it? Unique? Younique? Let's take a look at it. That's always suspicious. It's a liquid collagen shot. Is that what you're talking about? Let's see. It's marine collagen. It's got marine collagen peptides, hyaluronic acid, and girl, acerola cherry-derived vitamin C. So there you go, vitamin C. Can we say acid? Acid irritation? Let's see. So, yeah, so it's got ascorbic acid in it, which is going to irritate the bladder. Apple juice concentrate, mannitol. It's got citric acid, so you've got now a double whammy of acid. Peach concentrate, peach flavor liquid, and it's got malic acid in it. So we got 3 sources of acid and some potassium sorbate, which could also irritate your bladder. So I'm really thinking that it's going to be very interesting for you to stop that for a couple weeks and see if your symptoms get better. Carol said, saw your gynecologist on Tuesday and asked him to sign the forms to get a handicap placard. And his first reaction was, I don't fill these out. Ask your primary care. I told him she would never fill it out, especially if it had to do with a condition that requires a specialist. I then showed him the paragraph in your book, in the IC 101 book. Hello, IC 101, if you don't have that yet. And his demeanor changed. He said he wants to treat me more for my IC. I hadn't seen him in a year. The pandemic and treatments and medications he gave me in the past didn't help. He said he's not saying he won't sign it in the future. And I said, that's fair. What are your thoughts on doctors? Well, honey, I mean, I do think you should talk to your primary care about it. I mean, and what's the right way to say this? Do I consider IC severe enough to require a handicap placard? I think that there are periods of time when it can be, especially if you have Hunner's lesions, you know, where you're literally peeing every 15 minutes, and it's critical that you get to a bathroom as quickly as possible. But there are also people who are so mobility challenged, they desperately need that handicap place so that they can get into a wheelchair. And I don't think I've ever, even when my IC was really, really severe, I don't think that I ever considered that. I think that the IBS is interesting, though. I mean, the combination of the IC and the IBS, especially if your IBS is really, really aggressive, the combination of the two might do it. But, you know, we want to get you better so that you don't need to do that, right? I'm glad you showed him the IC 101 book. Judy says, my doctor has been doing a biofilm buster because you've had infection for months. Interesting, Judy. Hadar says, I felt like I had fullness, a pee in my bladder 24/7 without a break for 3 months. Then I was diagnosed with IC. Then I took amitriptyline Lyrica, and you got an 80% improvement on and off for 7 months. But now I suffer again for the last 2 months. I'm only in home 1 year. Okay, so Hadar, I mean, that kind of supports what I was saying, and that is that the nerves in your bladder are profoundly irritated. So the amitriptyline and the Lyrica help calm the nerves down. And you did get an improvement, but I still think we have to go back and look and see if there's anything in your daily life which is provoking your bladder. I mean, are you drinking water out of a Brita water filter? Some water filters are so good, they take out all the pH balancing minerals and you end up with acid water. So a lot of times there's a hidden irritant that you think is completely innocuous that's triggering your bladder. You'd be stunned at the amount of times I have that happen with patients that I work with. Lisa says, can you view this live feed later? Yes. The live feeds are available on YouTube and Facebook after the fact. Hadar says, I'm taking amitriptyline 75 milligrams, Lyrica 450 milligrams, pelvic floor physical therapy. You drink only water and coffee without caffeine. I would tell you to lose I would lose even the decaf coffee. And I would switch to Dandy Blend herbal coffee. The decaf coffee can still be quite acidic and irritating your bladder. I'm glad you're doing the Bladder Builder. I think you need to lose the coffee. You need to lose the decaf regular coffee. And I would really encourage you to switch instead to Dandy Blend. Let me go get mine. Hold on. All right, this is it, my friends. This is it, Dandy Blend. Dandy Blend herbal coffee. No caffeine, no acid, very, very satisfying. It's like I said, like I drink it every single day. I can drink several of these every day and it would never hurt my bladder. So I would really encourage you to consider trying a Dandy Blend. You've got to get off the regular coffee because it's not just the caffeine, it's the acid level. Regular coffee is very, very acidic. And that easily could be irritating your bladder. Judy says she hasn't started it yet, but the side effects can cause frequent urination. You're not going to know until you try it, hon. And sometimes it's just is what it is. Ann says, how do you know if your vagina is dry? Do you need estrogen? It hurts. Sex can be painful. Are you okay?
You got a section in the paper?
No. Leanne says, can we please talk about Botox? I just had a hydrodistension with 20 Botox injections last Wednesday. Now you're hurting really bad. And I think I have an infection starting. Everybody says 20 Botox is a lie. Is that right? I actually don't think I've ever seen a paper that's said how much is too much, to be quite honest, in terms of actual injections. Botox used to be a step 5 treatment. They moved it to step 4 when they discovered that by reducing the dose by half, we got rid of the serious adverse events. The problem with Botox is Botox turns nerves off. And so, so the theory behind using Botox in the bladder is if we can silence a nerve that's giving you frequency urgency and improve your discomfort, that's a win. But unfortunately, they also run the risk of silencing the nerve that lets you pee. And so the number one risk of Botox actually is urinary retention. And that is why Botox is never to be used by anybody unable to self-catheterize. You need to be able to self-catheterize, which is weird. The Botox is very popular in convalescent hospitals, and those are patients who can't self-catheterize. Anyway, they discovered that this lower dose reduced that risk. So they recategorized Botox from step 5 to step 4. But there's still always a risk of developing urinary retention. The fact that you're hurting really bad, it strongly, and it's how many days after? So it's Wednesday, Thursday, Friday, Saturday. So 5 days after your procedure, strongly suggests that you could have picked up a nosocomial infection. I would do a home dipstick test and as a preliminary, and if that comes back double positive, or if you're positive for nitrites, you absolutely need to call your doctor tomorrow morning. And if it gets so bad tonight, you might even need to go to urgent care tonight. Let's see how you do, but you're going to need to get somebody to rule out nosocomial infection. Nosocomial means hospital acquired in a medical setting. John says, I may need to have a Terp for prostate enlargement. I've not been able to find out how someone who already has pelvic pain would respond to that type of surgery. Have you talked with many men with pelvic pain who need prostate surgeries? I've talked to many, many men who have had Terps because in many cases, they're just told that's what they need to have done. Even though after the fact, they learn it was not related to their prostate. It was related instead to their bladder or muscles. So it's quite common. I guess it's kind of about what you hope it will do. Like, what are your expectations for having, and what are the doctor's expectations about what beneficial effect would a Terp happen to you? Now, if your prostate truly is enlarged and it's now protruding into your urethra, so you guys, another name for a Terp is Roto-Rooter. Sorry, John, but it is what it is. Basically, what they do is they stick up a device up the urethra, and when they get to the area of the urethra where your prostate is, if they see prostate tissue protruding, they go in and they kind of root it out. and that improves flow. Now we're no longer obstructed, but it is going to be painful, undoubtedly, which could then trigger some pelvic floor tension. John, men carry a special burden that women do not carry, and that is that your urethra is so long that anytime you have a procedure that involves your urethra, it definitely involves a bit more trauma, right? Dave says it took more than a year to get diagnosed. Oh, hey, listen, it can take 10 years for people to be diagnosed correctly, especially if you're a man, because you're often diagnosed with chronic prostatitis. And they just immediately put you on prostate meds or antibiotics for years before anybody looks in the bladder. And then they get to the bladder and the bladder's normal and they're confused. And that's because for many men, if not the majority of men out there, what we really are finding is a history of pelvic trauma that has caused very, very tight muscles, which is now compromising nerves. Hadar, wait a second. All right. I should have asked this at the beginning. You got IC when you had COVID. You had 3 times a UTI with E. coli. After 1 month, the E. coli disappeared. So, honey, COVID cystitis is real. COVID cystitis. So they knew in the earliest days of COVID that some patients were reporting a new round of urinary symptoms, frequency, urgency, pressure, pain, all the symptoms of IC, although it was more frequency, urgency, and less pain. But God, in like month 3 in Europe, they were a urologist treating COVID patients asked other urologists to look for any other urological complications of COVID. And then it was researchers up in Detroit and in Michigan who confirmed that and said, yes, we are seeing what we are calling de novo cystitis. De novo means new. These are patients who prior to COVID had no history of bladder issues at all. All of a sudden they get COVID and they got massive bladder issues. They're just peeing all the time. And so now that's been confirmed in a few other studies, and quite a few doctors are reporting COVID cystitis. And the question now is, what's causing it? And there are 4 underlying theories. Theory number 1 is it's the cytokine storm irritating your bladder. Just as all that damaging inflammation that is found in the lungs that leads to lung damage, those same inflammatory markers are found in the urinary tract. And so we know that that cytokine storm is reaching the urinary tract. So it could be that your symptoms are due to inflammation. The second thing we have to think about is, could it be active virus? Because they are finding active living virus in urine. And so we are finding virus in some of the more severe patients where there's viral infections in the bladder wall. There's another theory that because of virus it damages nerves, that the IC symptoms could be related to nerve dysfunction. And I forget what the 4th one was. It was not as important as the others. So that kind of changes your diagnosis to one of COVID cystitis as compared to interstitial cystitis. But there's no consensus about that because COVID is so new. The urology organizations haven't had the time to create protocols and guidelines and diagnostic criteria yet for COVID cystitis. So I'm asking lots and lots of people about it right now, trying to get more information on how to treat it correctly. So go on over to covidcystitis.org. Dave said, I've been in a flare for more than a year, always at work. Dave, what kind of work do you do? Jody say, I'm wondering if 2 arthritic hips could cause problems with my pelvic region. Hell yeah, absolutely. Absolutely. You know, there are some patients whose muscles just stay consistently and persistently tight. And the question is why? And we always have to go back to bones. We had a study that came out last summer. So last summer or 2 summers ago, of men with pelvic pain, and 70% of them had issues with their hip. Dave said, is alcohol always a trigger? In our survey with alcohol, 95% of patients reported alcohol is triggering their flares, but it depended upon what type of alcohol. So, and so I've got articles on that on our website. We did a very long study on alcohols, trying to find the ones that were bladder friendly versus the ones that weren't. So with respect to beer, it was the pale ales that were much more bladder friendly than the Guinness, the dark ales. And I love Guinness. But yeah, but the pale ales for most people is just more bladder friendly. With respect to wines, you want to do a low acid wine, such as a Merlot if you like red, or Chardonnay if you like white. For hard alcohols, it was the clear alcohols that were far more well tolerated than the brown alcohols like rum. And the alcohol which was the most bladder friendly was sake. Sake. The other thing I would throw out there is that even though I'm in the wine country and my sister is a winemaker and I worked in a wine lab for 5 years while I was in graduate school, I don't really like wine that much. I love hard cider. I like fruity things more rather than more kind of the esoteric, fancy palate, of wine. I just don't vibe with it. I like something that's really, really fruity, and so I go for hard cider, like a hard a blackberry cider or a hard pear cider. And the best that I will tell you all, the single best cider I have ever had was a pineapple hard cider made by Ace Hard Cider in Sonoma County. Oh my God, the flavor was insane. Oh my God, was it acidic? It burned the hell out of my bladder. But you guys, I want to show you something. I found something interesting. Hold on. Okay, so I am not a soda drinker. I've never really been much of a soda drinker at all. I don't know. I just don't like things that are really, really sweet, and I never have. So I've never been a big soda drinker. My mom, who's 93, loves her root beer. And so I ordered this for her from Imperfect Foods, and it's called Olipop Classic Root Beer. But you notice it says sparkling tonic. So it's not a real root beer. It's not a root beer soda. You know what it is it's a, what's the right word for it? It's got prebiotics, fiber, and botanicals in it. So it says, we spent years crafting a drink that's as good as for your digestion as it is delicious. Olipop combines the benefit of prebiotics, plant fiber, and botanicals in a sparkling tonic that supports your microbiome and benefits digestive health. Our old-fashioned root beer melds just the right mix of classic bite and creamy sweetness with extracts of sweet birch, smooth vanilla bean, and real burdock root, which is the source of root beer. Okay, so what is it? What's in it? Carbonated water, And it's got cassava root fiber, chicory root inulin, Jerusalem artichoke inulin, natural cactus, calendula powder, kudzu root, marshmallow root, slippery elm, cassava root syrup, a little bit of apple juice, and organic natural root beer flavor, little tiny bit of lemon juice, burdock root, stevia leaf, etc. Okay. So I didn't really know what I honestly, I just thought it was root beer. This is so good. Remember, now I'm a little bit older than a lot of you. Back in the old days, we used to have A&W root beer. And they would come out with a big, giant, thing of it. And we'd all have our frozen mugs, the glass mugs that were kept in the freezer. They bring them out. They pour the root beer in it. Divine. Like my childhood was, I had so many of those moments of A&W root beer in a frosty, cold blast, right? And a lot of the root beer you get today is just not as good. Okay, this is insane. It is insanely good. And it has, as my sister, I showed it to my sister last night. She goes, it has 9 grams of fiber in it per bottle, and it's only 35 calories. 35 calories. It's incredibly good. Now, I'm going to say the only thing I notice, now you guys, I have no shame, I will say anything, is that I fart for a couple of hours afterwards. You know, some nice passing gas after drinking this, but it hasn't upset my stomach or my bladder or anything done. And we are all on a quest for increasing our fiber intake. So I've been drinking one of these a day for about 2 weeks. And I drink it. I don't drink it in the morning. I don't drink it when I'm out, especially in a group of people, because the odds are you're probably going to be farting a little bit. I drink it like at 8 o'clock at night or 7, usually around 8 o'clock at night, because I stop eating at 8 o'clock. So like 7:45. So let me just put the brand up again. Olipop, OLIPOP, classic root beer. It is so good. I mean, it's really good. And they're not paying me to say this, guys. I've never talked to the company, but the flavor, Donna says she remembers A&W. This is the exact flavor. It's so good. So I got mine from Imperfect Foods, but they have it at our grocery stores too. But it's in the refrigerated section. Diana says, is spring water bad for your bladder? Absolutely not. Spring water is absolutely the best thing you can do for your bladder. Hadar says, if I do a hydrodistension, can it make the fullness feeling stop? Well, I wouldn't consider doing a hydrodistension until you lose the coffee for a couple months. Because again, take my word for it. With the patients that live with long-term chronic intense symptoms, it's either untreated Hunner's lesions or they're doing something every single day, which is tweaking the hell out of their bladder. And it's usually a multivitamin, or it's a drink that they love that they haven't been able to give up, like coffee. And it's the patients who drink 1 cup of coffee a day, they're the ones who suffer the most, because literally the bladder can never heal. You know, we learned this at a National Institutes of Health conference years ago, is that when the bladder wall is damaged, there's little tiny stem cells. It takes 2 weeks for the stem cell to grow and adapt and change and fill in where that umbrella cell has been damaged in the bladder wall. And while that stem cell is trying to do that, it is easily destroyed by acid. So the rule of thumb is 1 cup of coffee will destroy every single stem cell trying to repair your bladder. So you set yourself back 2 weeks worth of healing. That's why for coffee drinkers, we want you off of the coffee for like 2 months to really give your bladder an opportunity to heal, or at a minimum, lose that coffee and come to this coffee, Dandy Blend, herbal coffee, which has no acid in it, and it's not going to hurt your bladder, and it's not going to kill those stem cells. And that's what I'm drinking right here. You know, I mean, it's just, it's worth me telling this story over and over and over again because it really makes the point. I had a patient call from New York years ago. Very, very shrill voice. I'll never forget her voice. Newly diagnosed with IC, almost hysterical with pain. Spent like an hour with her on the phone, went over everything, told her about the diet, everything. She happened to live in New York, sent her off to see Rob Moldwin, with the top doctor in the area. And I didn't hear from her again for like 5 years. And she called back and she was again hysterical on the phone. Jill, I've done everything. Nothing's worked. Please help me, help me, help me. Nobody's helping me. None of these doctors are helping me. And she was in a lot of pain. And I said, okay, tell me about the pain. And she was having very clear bladder wall pain. Pain is the bladder fills with urine that is relieved by urination. And I went, hon, gosh, you know, God, it really sounds like your bladder's being irritated. Are you following the IC diet? And she goes, yes. Her husband was on the phone. He goes, are you kidding? She drinks a pot of coffee in the morning and a 6-pack of Diet Coke in the afternoon. She's never followed the diet. And you want to hear somebody wail? She started wailing. She was screaming over the phone. That's right. Take away everything I love. I have no reason to live if I can't have my coffee and my soda. It's just really way over the top, right? And I said to her, I said, now listen, I know I told you about diet. Didn't you believe me? She goes, no. I said, I know I sent you to Rob Moldwin. Didn't he tell you to stop the coffee? He goes, yeah. I said, didn't you believe him? She goes, no. And she saw 5 doctors. She spent about $25,000 doing treatments, including Interstitial, that didn't work for her. Nothing worked for her. And as I said to her, I said, do you realize that you have sabotaged every treatment you have done? She was like, what? I went, yeah, nothing could have worked for you with the amount of acid damage you were doing on your bladder. How much money did you spend? $25,000. None of it had a chance to work with what you were doing. There is no treatment that can counteract the damage done by that amount of acid. Period. End of story. You have sabotaged everything. And she's like, I don't understand. And I explained the stem cell thing. It's like, imagine an extra large pizza and a little tiny green pea underneath the pizza. The extra large pizza is your umbrella cell, the biggest cells in the human body composing the bladder lining. When one of these cells is damaged, there's a little tiny pea underneath it, a little tiny stem cell. And it takes 2 weeks for that stem cell to grow and change shape to become the pizza cell, the umbrella cell. And during that 2-week period, that stem cell, as it's growing, is exquisitely vulnerable to acid, and it will be destroyed, according to Dr. Anthony Schaefer. So if you're drinking 1 cup of coffee a day, no treatment you will not get better. You are preventing your bladder from repairing itself. And in her case, she was doing massive damage to her bladder. It is no wonder she was hysterical with pain. I would have been hysterical with pain if I was doing that. Plus, she was menopausal. So she already had severe estrogen atrophy, so her bladder had no coating anyway. So she was just bathing the nerves in her bladder with acid every day. She was in agony. She called me back 3 months later. She goes, oh my God, Jill, I'm better. And I went, really? And she goes, yeah, I finally stopped the coffee and the soda. Because I told her she was an addict. I said, you're an addict. You're just an addict. That's a problem. And she's like, you're right. You're right. So it just took 3 months of her not drinking all that coffee and all that soda for her bladder to start healing. So it's important. Dave said, I can live with the frequency and urgency. It's a constant pain that's debilitating. You're in sales. You're always on deadline and on my feet. Dave, is the pain positional? Is it fine when you stand, and does it get worse when you sit down? And Dave, I'm sorry. I know that I'm like 10 minutes late in answering yours, but this is the way of these meetings. So if your pain is positional, if you're fine when you stand, but when you sit down it hurts, that means you've got pudendal neuralgia. It means you have a muscle injury that's squeezing nerves. And that's generally what we see. But I would love to talk with you if you'd like to call this week, because my main specialty is interstitial cystitis, but my subspecialty is interstitial cystitis in men particularly, because I worked with men for over 30 years because my first support group was filled with men. So I try to talk to everybody, but I really always try to give extra time to men because you don't get the care that a lot of women get. Torito says, "Ooh, how can I get vaginal estrogen? It seems to be coming out, especially when I have to pee. I have to wait 45 minutes." Torito, normally we use vaginal estrogen at night before we go to bed. Sandra said, "What type of hot tea is okay? Chamomile herbal tea, peppermint herbal tea, or rooibos teas are usually bladder friendly." Carol says, "When I saw my urogynecologist, he said I had a UTI with blood in my urine, and I said, no wonder I've been miserable. I just thought my IC was acting out. He mentioned D-mannose, but I told him I tried it and got diarrhea from it. I called my pharmacy, and they said they had to order a D-mannose powder. I can't believe he called it in after I told him I have a IBSD, and it gave me diarrhea. He called in a prescription for pyridium, but he forgot to call in the prescription for the antibiotic." Yeah, you said that on Friday, hon. She says, "What's wrong with some of these doctors? They're very distracted." Listen, being a doctor, especially now, is very, very difficult. And they deserve our sympathy because they have lived in hell in the last 2 years trying to care for patients with COVID while protecting themselves and their family. And we have lost some good doctors who got COVID and died. And so I think it's very, very important that we show them kindness and compassion, because we cannot imagine, for those of us who are not in their position, their stress level is off the charts. I mean, we have medical care providers who are committing suicide because of the stress right now. And so let's be gentle to our medical care providers because we need them. They are human too, and they are operating under insane conditions right now. Denise says, "I gave up coffee and soda. It took time to heal, but now it's repaired and I'm fine." Awesome. I just take a few sips of my husband's coffee and his soda and I'm satisfied. Yeah, that works. So Dave, your symptoms are worse when you need to walk. So Dave, when you get up in the morning, do you feel, when does the pain start? Do you wake up in pain, or does the pain start as soon as you start walking in the morning? Hadar says, "Well, what happens to the nerves in the hydrodistension? The nerves are broken. It's a destructive therapy. A hydrodistension is not constructive. It does not help build up a healthy bladder wall. The reason why you feel better after a hydrodistension is that it breaks the nerves that are giving you the symptoms of frequency, urgency, pressure, pain. But those nerves will always grow back. Your symptoms will return. And the problem is that quantitatively more nerves come back. So every time you do it, let's just throw out an abstract number. I'm not saying this is correct. Let's just say prior to hydrodistension, you had 10 nerves. Post hydrodistension, you have 15. You have it again. Post hydrodistension, now you have 20, double the amount of original nerves. Now, I'm not saying that that's statistically accurate, but I'm saying that is the risk of doing a hydrodistension. It's more nerves. The human body compensates nerve injuries by helping more nerves grow. So hydrodistension is injuring you. Diet is first. There are no risks to diet. There are significant risks to hydrodistension. Okay, Dave. Dave says the pain is all out front. Okay, so Dave. Oh, I love talking with you guys. So, and sometimes it's like pulling a needle out of a haystack or water out of a desert. So when you say out front, are you saying that you're having pain in your lower abdomen? Or are you having pain in your penis or your testicles? So where is your pain? Okay. And he says, okay, so his pain begins almost after you get up. It seems to be related to fluid consumption. You only drink water during the day. Pain seems to be worse when my urine isn't clear. So I've been drinking more water during the day. But that doesn't explain why walking is hurting. You know, an injured bladder does not make it painful to walk, usually. I mean, an injured bladder makes you pee all the time, but it doesn't, you know. And so again, we have the chicken versus the egg. Which comes first, the chicken or the egg? So generally, again, in my office, this is in my office, when men call and we go back through history, we find a history of muscle trauma. So were you a motorcycle rider, bike rider? Have you ever fallen and broken your tailbone or just had multiple falls? I would really want you to have a proper pelvic floor assessment. Were you a bike rider or motorcycle rider? Even as a kid? No, you were pretty lazy. Okay. When you go to pee, can you start your stream right away, or do you hesitate 5, 10, 15 seconds before you can release your urine? You guys on YouTube, you're being pretty quiet. Unless I'm missing something. Nope, you're being quiet. So you hesitate, that it takes a moment to relax. So the fact that you're hesitating points to two potential things. Number one, that your muscles are tight. You know, urination is normally about relaxation, that literally a muscles relax, the sphincter opens, and you pee almost instantaneously. If you can't start your stream right away, that's a very distinctive symptom that could suggest that your muscles are very tight, or it could suggest that you're having, again, maybe a prostate issue. Do you have when you sit down, do you feel a sense of vibration? You feel like a fluttering or a movement in your pelvis, like in one butt cheek, or even maybe all the way down by your foot? Do you have any? Okay, the doctor says your prostate is good. That's excellent. So that points us to muscles. So again, when you sit down, are you feeling any fluttering, vibrations, anything at all like that, especially as the day winds down? You've been at work for several hours. All right. So you're feeling the fluttering when you're driving. All right. So there you go. So what are the risk factors of pelvic floor dysfunction, but sitting for a long period of time? They call sitting the new smoking. The longer you sit, the greater the risk that your pelvic floor muscles are going to become dysfunctional. And the fact that you have fluttering when you drive proves it. It basically proves it, because I have exactly the same thing. And in fact, my left butt cheek right now it just started fluttering a little bit. And it doesn't hurt, but if I kept sitting here for a long period of time and ignored it, it eventually would get to the point where it would flutter more violently and then really hurt. So, okay, what do you mean? The fluttering is better at the end of the day? I don't understand that. Generally, the longer you sit, the worse it gets. Hadar says, thanks, Jill. What do you think about the installations of Enlargement, chondroitin sulfate, and hyaluronic acid? It's called Ioloril. Another brand name for that is called Ioloril. Hold on a sec. So, Enlargement, this is an interesting. So this is that new pre-filled installation that uses this new device where you insert it up to your urethra, and you don't have to go all the way into your bladder. It's making installations much easier. Only used in Europe, not used in the US that I'm aware of yet. Let me see. Hold on a sec. I do not think it's approved here in the United States. Is somebody giving it to you? Are you in the US? The combination of chondroitin and hyaluronic acid is a good combination. They're far more successful using both of these medications together than separately, and the research supports that. And the Enlargement little medical device is fantastic. All right, so he said, okay. Oh, always nice to work with my Israeli friends with IC. I mean, I think it's, again, it's a viable option. Would it help COVID cystitis? I don't know. We just don't know enough about it yet. Right. David said symptoms are better late in the day, and also, they disappear after you get home and recline. So your symptoms are influenced by gravity, which again, that's really pointing us due to muscles and nerves. Dave, you need a pelvic floor assessment. That's a huge, huge symptom. I mean, you've got to, in fact, listen, you need to get this book, Breaking Through Chronic Pelvic Pain. This is a masterclass in pelvic anatomy and pelvic injury. And the case study, many, many case studies in here, really good success stories. I think it would help. I mean, the fact that walking makes it worse, and the fact that it goes away when you get home and you recline, then we're talking about weight bearing on muscles, and how those muscles in your pelvis are then affecting your bladder. I think you are yet again another gentleman who, underneath it all, has an underlying pelvic injury of some type, pelvic tension of some type. And it could just be from your choice of work, just sitting for long periods of time. I mean, I was very athletic when I was younger, but man, once I had started working, especially working on the IC network for 29 years. There's a lot of sitting involved. And the day I got that vibration, I had been sitting for probably 14 hours straight trying to solve a coding problem with the IC network website. And bam, I'd even stepped away from this computer, and I was sitting on the floor in my living room, and I on my ankles to lift my crotch up off of the floor. And that's when it started. And I've had it to this day. And it is a pudendal nerve entrapment from tight piriformis muscle on my left side. And if I keep my muscles calm and healthy, and if I do my massage, and it's not external, it's internal massage, when I start feeling that muscle starting to get tight and tension and lifting off of the bone, I got to get in there with my wand and calm that muscle down. And it's annoying as hell to do that. You can't reach these muscles from the outside, you have to do it internally, but it works and patients are cured. And that study from UCLA proved that pelvic floor dysfunction patients respond the best to pelvic floor therapies. I think you need, David, I'm looking at you. You need a pelvic floor assessment. We need to see what's going on with your muscles. And you need to talk to them about mobility and how it's getting worse as you're walking, but that it goes away when you get home and recline. I think there's an underlying muscle thing going on there for you. I did want you guys to know that the Environmental Working Group released their new list of the Clean 15 and the Dirty Dozen. One of my passions as a support group leader is is consumer outreach and consumer activism. Obviously, that's why I shared with you guys the Elmeron eye issue, along with many, many others. I think that for Americans here, our food industry and our chemical industry are complicit in giving us things which are highly toxic, that we are eating and drinking things that are banned in other countries. And it's disgraceful, absolutely disgraceful. Last year, so the Environmental Working Group is a nonprofit that goes over the FDA's own test results. They don't perform their own. They get their test results right from our government. And their purpose is to try to identify foods that are toxic. I mean, with the crazy amount of cancer that we're going through right now, especially the crazy amount of cancer in animals, it's just so sad, the tumors that are just appearing in animals all over the place. That's fire retardants from furniture, but it's also potentially contaminants in their food. So anyway, last year, for example, the Environmental Working Group found that 100% of raisins tested were contaminated with pesticides. But even more shocking, 97% of organic raisins were contaminated with the exact same carcinogenic pesticides and other toxins, which is why we stopped eating raisins in our family immediately. Immediately. Like, I want my family to be safe. So anyway, they just released last week their Clean 15 and Dirty Dozen. So let's go through their Dirty Dozen. So the Dirty Dozen, these are the foods which absolutely had the highest rate of pesticides in the meat of the fruit. And we're not talking the skin. You can peel the skin off. The pesticides are in the meat of the apple slice, right? So the number one Dirty Dozen food was strawberries. And that makes sense. I mean, like, I live in California. California grows the great majority of fresh fruits and vegetables for the United States. You drive down the California coast, you go through farmland. In fact, it's destroyed the monarch butterfly habitat because it's so massively overplanted. But what you don't know is that they destroy the soil. That literally the soil is infused with pesticides to kill bugs, including earthworms, which is ridiculous. And then they kill the soil. They cover the soil with plastic, then they pump all sorts of fungicides and stuff underneath the plastic, let it permeate. Then they poke holes in the plastic and they plant the strawberries in it. And then they, grow it. And there's nothing normal and healthy about this. Nothing. The meat of strawberries is massively contaminated with pesticides. The best thing you can do for strawberries is buy organic, or better yet, grow them in your own yard where you can control what that is exposed to. It's just shocking what they do. So number 1, strawberries. Number 2, spinach. Number 3, kale. Number 4, nectarines, which say thin skin fruits. Number 5, apples. Number 6, grapes. Number 7, bell peppers and hot peppers. Then cherries, peaches, pears, celery, and tomatoes. So these are the foods that they say buy organic. The pesticide rate is just too high. Buy organic of these. So again, strawberry, spinach, kale, collard and mustard greens, nectarines, apples, grapes, bell peppers, cherries, peaches, pears, celery, and tomatoes. Okay, so those are the most recent ones. But they also have a list called the Clean 15. And the Clean 15 are the top 15 fruits and vegetables that had the least amount of pesticides. So these are the ones that you can buy regular, not organic, with confidence that they're safe. So number 1, avocados. Makes total sense. A nice thick coating of avocado keeps the pesticide from getting absorbed. So the Clean 15, avocados, sweet corn, pineapple, onions, papaya, sweet peas, asparagus, honeydew melon, which is one of my favorites, kiwi, cabbage, mushrooms, cantaloupe, mangoes, watermelon, and sweet potatoes. Okay, so again, avocados, sweet corn, pineapple, onions, papaya, sweet peas, asparagus, honeydew melon, kiwi, cabbage, mushrooms, cantaloupe, mangoes, watermelon, and sweet potatoes. So those, they say that the exposure risk is much less, and you can save your money and buy those regular. Like I don't buy organic avocados, so I buy regular. So I wish that our food producers were not so manipulative. There have been a lot of videos, people who compared the same cereal, like a classic American cereal. So let's just throw out Raisin Bran or Honey Nut Cheerios or whatever. If you compare the ingredients of that same cereal in Europe as compared to the United States, they're massively different. People go to Europe and they eat the same, they think they're eating the same foods as the United States, but you know what happens? They lose weight. They lose weight. And they're like, wait, why am I losing weight? I'm eating exactly what I ate at home. Until you look at the ingredients. Our American foods have massive amounts of sugar and high fructose corn syrup that they don't have in Europe, as well as other ingredients, including wheat that's been compromised by Roundup and all that sort of stuff. Like when I buy cookies, if they're either homemade cookies I make with organic flour, or I buy cookies from Europe. You know, the little butter cookies, which are really good for my parents. Donna says, when I visited Germany, I felt so much better. Yeah. I mean, we've got to take back our country from these corporate interests who put profit ahead of our personal safety. It is disgraceful. The foods that we are giving to children are massively contaminated. And, you know, the whole fire retardant thing, you want to know why your cats and dogs are dying of cancer. It's from the fire retardants that they put in foam that's completely unnecessary. So a lot of the furniture that was produced here in the US in the last 30 years. I mean, it was finally banned like 5 years ago. At least in California, it's banned. Absolute 100% connection to cancer. So they put it in the foams in your beds and in your furniture, and that foam breaks down, and it breaks down into dust. And who's on the floor walking through the dust? Your infant or your pet. And these are what they call what's the right word for it? They don't break down in the environment. They measure these fire retardants in our bloodstream. And they are high in children who are crawling on a floor contaminated with fire retardants from furniture. And that's why if you're going to get furniture, do not get furniture from, you always have to ask the question, is this treated with fire retardants? I wouldn't trust any of the big dealers at this point in time. You have to really go green and look for environmentally safe furniture. We've seen some pictures of these dogs with these giant tumors hanging off of their chin. And that's just because they've been laying on the floor and their chin was on the floor and the cancer-causing agent was on the floor. Sorry, sometimes I rant about that, but it's a good rant. Kalina, what Dave says, cannabis seems to help in the morning. Okay. I mean, in the evening. So Dave, just make sure that your cannabis isn't contaminated with pesticide. That's also a problem in the cannabis industry. So whatever you're buying, make sure that the website has consistent safety testing reports. Kalina says, my pelvic floor physical therapist is only doing external work. I feel she's wasting my time. Where can I find internal instructions so that I can do it myself at home? Oh, hun, has she explained why she's not doing internal work? What is her explanation for why she is avoiding the single most effective way of working with the pelvic floor? Has she just not been trained? So there's a website called Pelvic Rehab, pelvicrehab.com, where it's a listing of all the physical therapists that do this work in the United States, and you can find those that are certified. So if that physical therapist is only doing external work and you would like internal work, I think you need to change physical therapist to somebody who has the right certification. She just may not be trained how to do it correctly. And you doing it on your own is almost impossible. You need somebody to at least identify the muscle groups. So at going to at least one session with a physical therapist who's doing an internal exam and touching muscles, if they can identify which muscle is the problem, then you can take that information, maybe go to YouTube and try to figure out how to work on that muscle. But so Kalina says she only did it once internally and she thinks external is better. Wow, I disagree with her completely. All the research shows that internal work is, in fact, that very first IC clinical trial with physical therapy had one group that did internal work and one group that did external massage. And the internal group was far more successful. And the proof is in the results, hon. It's in how you feel. I mean, if you don't feel like you're getting better, then she just may not have the training. And so go to pelvicrehab.com. It's a great database, and it will tell you who's trained in your area. Lisa there says internal work is so much better. It is. I have to totally agree with that. It is. I'm very itchy today. Allergies are crazy. My whole body is just all itchy, weird today. Kalina says you've had 12 appointments and you feel worse. Well, so normally I would say you would do 2 appointments and then she would do another internal exam and see if she's making progress. So 12 appointments, I would say, I would like you to do an internal exam and let's see if my muscles haven't changed for better, for worse. The fact that she's only did it once So you really have no idea what's going on with those muscles internally then, and that's a problem. Because internal work is far more successful than external work, according to the experts, and me personally. I wanted to see if I could find maybe let me just see if I can find in Dr. Weiss's book. Let's see here. Oh, hey, listen, here's one for Dave. So again, this book is the bomb. It is such a good book, Breaking Through Chronic Pelvic Pain. It's a love letter for patients with pelvic pain. And this was literally, in my opinion, the best book ever written for patients with pelvic pain. It's just so beautifully written. So this is chapter 10, Treatment for Pudendal Nerve Entrapment. This may come as a surprise, but you, the patient, hold one of the most important keys to the successful treatment of pudendal nerve entrapment. Believe it or not, your practitioners can perform every treatment trick in the book and accomplish very little if you don't pay close attention to what you sit on, wherever that may be. This is a basic requirement for minimizing trauma to an already grumpy pudendal nerve. Many of my patients actually choose their restaurants not by the food on the menu, but rather the chairs at the tables. One gentleman told me that he once walked in and out of 3 restaurants before he found a seat that didn't frighten him. This extreme tactic can usually be avoided, however, with the use of a special cutout cushion that you carry with you to those places where seating is likely to be suspect. These include theaters, stadiums, banquet halls, waiting rooms, public transportation, even your friends' homes. In other words, don't go anywhere without it. If you encounter a hard surface or one that pushes up between the sit bones, put your cushion down and tell curious onlookers it's for your bad back. And as for your home or office, it goes without saying you will be sitting on these cushions there. All right, so here's Eric's story. Eric's story poignantly illustrates how the simple act of sitting in the wrong chair can inflame and entrap the pudendal nerve with potentially devastating consequences. It also highlights the need to educate physicians to recognize pudendal nerve pathology and make a correct diagnosis when evaluating pelvic pain complaints. Eric was 36 years old at the time of his initial visit with a 10-year history of pain with sitting. He described the quote, sensation of a golf ball up his anus and perineum with soreness at the base of his penis and under the right sit bone. He also mentioned that on several occasions he had experienced pain in the urethra, testicles, and lower abdomen. It all began when he sat on a weird chair with a lump in the middle. Since he initially had urethral and scrotal pain with a hesitant and slow urinary stream, he was referred to a urologist who prescribed the standard antibiotics and Flomax to relax the bladder neck. The question not answered was, why did Eric have pain symptoms only when sitting on a chair? After seeing 20 urologists and taking as many courses of antibiotics for presumed prostatitis, the pain with sitting remained. This 27-year-old man in a very lucrative profession had to quit his very lucrative job. He was unable to focus enough to do any type of work. Fortunately, his wife, who enjoyed sewing, wanted to help. After much experimentation, she constructed a cushion with a cutout in the center that significantly reduced his discomfort. It then occurred to her to market the cushion for patients with prostatitis who, like her husband, had pain with sitting. And it was a stroke of luck for Eric when a patient of mine purchased one of his wife's cushions. The gentleman brought it to my office because he found it to be helpful with his pudendal nerve pain. I was intrigued with the cushion and thought it might benefit some of my other patients, so I phoned Eric's wife to request a demonstration sample. When she related her husband's story to me, I explained that his symptoms were not those of prostatitis and suggested that I have a phone consult with him. He called immediately, and our conversation led to an office visit. Eric's pain with sitting was in the distribution of the pudendal nerve, the perineum, the scrotum, the penis, and the urinary sphincter. On examination, he had a very tender skin around his rectum, both with pinching and pinprick. When I touched the left pudendal nerve, it was so tender that he almost jumped off the examination table. The diagnosis of left pudendal nerve entrapment was made, and he was treated with a cortisone nerve block. The pain subsided immediately, and he's able to urinate better than he had in 10 years. Eric then broke down and began to cry. Imagine having 10 years of pain, unable to work with a life on hold, and not seeing any further hope for relief. He had been alive but not living. If it had not been for his wife's cushion that found its way to my office, this young man with a once promising future might have been sentenced to a life in pain prison. Cars pose another challenge. My office is now well supplied with cushions, and every P&E patient is encouraged to use one. However, in spite of the use of this cushion, many of my P&E patients still complain about pain when driving. In fact, symptom flares from car seats have prompted some of them to either sell their cars or attempt to have a custom seat fabricated. One patient commented that her friend thought she was crazy when she sold her beautiful new Mercedes because she couldn't take the pain from the stiff, hard seat. Another patient made an interesting observation. He had developed numbness in his buttocks and pain in his posterior thighs when driving his 1990 automobile. In 1993, when he purchased another vehicle with a softer seat, his symptoms cleared. Then in 2000, after 7 symptom-free years, he had a return of buttock pain when he sat on the hard seat of his new car. With these and other patient anecdotes in mind, I asked mechanical engineer Samuel Goldfarb if he could explain why seats in newer cars seem to cause more pain in P&E sufferers. He kindly investigated and offered to write the following commentary. And it's a whole article on how to shop for a car. Basically, since the 1990s, car manufacturers have followed the European tradition of making cars with hard seats. Shorter seat bases, et cetera, et cetera. So you can read this whole section in Breaking Through Chronic Pelvic Pain. Let me see too, getting back to the internal massage. All right. This is in his chapter on urinary syndromes. What is it about the words interstitial cystitis that strikes fear in the hearts of our strongest men and women? I have patients coming to my office in a state of panic. They've gone online to find out about IC, chatted there with people who are suffering from the condition, and come away with the impression that it's an incurable disease of unknown cause that leads to lifelong incapacitating urinary urgency, frequency, and pain. They've also come away with the impression that there is no treatment with a high probability of providing long-term symptom relief. In my opinion, that is an old view based on old treatment options. A new view is that all IC symptoms do not originate in the bladder. Rather, the muscles of the pelvic floor and the pudendal nerve may be causing many or all of them. Since the pudendal nerve controls these muscles, when it is injured or irritated, it can lead to muscle tension that leads to the development of trigger points and overall muscle dysfunction. The muscles can also become overstressed from a number of other causative factors and in turn injure the pudendal nerve. Should this be the case, the nerve injury can then enhance the muscle dysfunction and pain, leading to the development of a self-perpetuating mechanism that can sensitize the entire central nervous system. Can we say central sensitization? The good news is that we can frequently alleviate IC symptoms by treating pelvic floor muscles. Ultimately, pelvic floor muscle dysfunction with or without pudendal nerve involvement can trigger and perpetuate changes in the bladder lining associated with IC, and thus play a significant role in creating the symptoms, perhaps even initiating the disease. Therefore, the good news is that we can frequently alleviate IC symptoms by treating the pelvic floor muscle and or pudendal nerve components. Because in my experience, muscle involvement predominates over that of the nerve in creating the symptoms associated with IC, it will be the primary focus of this chapter, though certainly the nerve will be given the coverage it rightfully deserves. Urinary urgency frequency syndrome and IC have dysfunctional pelvic muscles as a common denominator. Patients with both of these conditions have tight pelvic floor muscles that squeeze the urethra, producing the compelling and frequent urge to urinate. However, with IC patients, the muscle component is more severe, and the bladder is involved in a pathological process that causes them to experience pain when it fills, in contrast to just the normal discomfort of frequency urgency. Though I will discuss these syndromes in tandem here, the emphasis will be on IC. This is because it is a more complex problem requiring a broader treatment approach to address bladder involvement. Nonetheless, given that urgency frequency and IC share the same pelvic floor muscle dysfunction, they have a lot in common. So if you're suffering from urgency frequency but not IC, read on. The information I'm about to present to you is also important. All right. The purpose of this chapter is not to review all possible theories regarding the origin of IC or to provide an exhaustive review of traditional diagnostic methods or treatments. Instead, the intent is to present a new treatment approach based on 40 years of observation, treatment, and clinical research. I'm telling you guys, Dr. Jerome Weiss is a hero. He is the ultimate IC angel for what he has done. So let's go through this. Urgency frequency, also known as urethral syndrome, is characterized by a frequent and urgent need to urinate with a persistent sensation of fullness in the bladder. Trips to the bathroom constantly disrupt patients' lives, in some cases as often as every 15 minutes, with the possibility of embarrassing accidents that can be psychologically devastating. This syndrome is most prevalent among women and is generally not always present with IC. Interstitial cystitis is a poorly understood condition characterized by symptoms of urgency, frequency, and or pressure with moderate to severe pain in the pelvic region that can vary greatly from one person to another. Pain typically intensifies as the bladder fills and is relieved with urination, and it may radiate to the lower back, upper legs, vulva, or penis. Though available statistics indicate that approximately 90% of IC patients are women, this estimate is likely to change because increasing numbers of men who were previously diagnosed with chronic prostatitis are now being given the diagnosis of IC. The term interstitial cystitis is derived from cystitis, meaning inflammation of the bladder wall, and interstitial, meaning intercellular or space within the cells. It was first used in 1887 to describe a disease characterized by ulceration and inflammation of the urinary bladder lining. Since then, the diagnosis has evolved to include ulcerative and non-ulcerative categories. Hello, Hunner's lesions. With lesions found in less than 10% of patients, this has resulted in confusion and controversy. The confusion centers on the inflammatory component, which is not found in the bladders of 90% of patients presenting with typical symptoms. If indeed these patients have inflammation, it is not observable and does not respond to antibiotics, nor as does ordinary UTI. Consequently, in recent years, the syndrome's medical designation has been changed to painful bladder syndrome and then to bladder pain syndrome. But neither of these designations have taken hold with most practitioners and their patients, who continue to refer it to IC. My new view regarding the treatment of these troublesome symptoms was conceived during my early clinical professorship at the University of California, San Francisco, where I was fortunate to have an association with pioneers in the field of pelvic floor muscle dysfunction. There, urologist Dr. Richard Schmidt, working alone in collaboration with a number of colleagues, performed a series of groundbreaking studies of patients who experiencing frequency urgency. This work shed considerable light on the dynamics of the pelvic floor muscles by demonstrating that these symptoms were caused by tight, hyperirritable, unstable urinary sphincter muscles and not by the bladder. In 1981, Dr. Schmidt published a paper with this is interesting, so I'm going to keep reading it. It's not that long, but I think it'll give you some insight here. In 1981, Dr. Schmidt published a paper with Dr. Chanago on urethral syndrome with no sign of infection. They reported among their findings that in all cases, patients with this syndrome had increased discomfort and urge when the urethral sphincter pressure was high, as with a full bladder. Conversely, when the pressure dropped, as with urination, they experienced a corresponding decrease in symptoms. Furthermore, they discovered that many patients experience relief from urgency only when relaxing their pelvic floor muscles to void. Their conclusion was that urethral syndrome was a muscle problem, not a bladder problem, and they cited relaxation of these muscles as a primary treatment objectives. All right, I just keep going here. 1991, Dr. Schmidt and Vapnek shed further light on pelvic floor muscle dysfunction with a study involving patients with IC. They found that IC patients exhibited the same increased tension and abnormalities in the behavior of their urinary sphincter and pelvic floor muscles that had previously been documented in patients with severe urgency frequency. Their very significant conclusion was that IC patients' urinary symptoms were more likely to reflect changes associated with these muscles than changes in the activity of the bladder wall. Schmidt and Vapnek also explored the pain component of IC, noting that pressure applied to pelvic floor muscles could cause pain, and that assessment of these muscles was not generally included in evaluations of IC patients. In their patients, upon the application of pressure, the tender muscles referred pain anyway, we all know that. Hold on. Furthermore, Dr. Schmidt and Vapnek discovered that IC patients had no voluntary control over their pelvic floor muscles and therefore could not consciously relax them. They demonstrated that IC symptoms could quickly improve if these muscles were relaxed using biofeedback or nerve stimulation. All of their muscle findings are compatible with the presence of myofascial trigger points that refer pain to other areas, weaken the muscles, and create symptoms in the autonomic nervous system. All right, and he goes over lots of others. So collectively, the studies I've just cited demonstrate not only that the pelvic floor muscles contribute significantly to the symptoms of urgency frequency in IC, but rather these muscles were likely the primary cause of both syndromes. I found the study results for IC to be particularly encouraging, as the standard treatments that have been targeting only the bladder had dismal outcomes. If, as these results indicated, pelvic floor muscle dysfunction was indeed the root of this debilitating condition, I saw evidence. So he did his own study, yada, 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 yada. Let's see. 28% of IC patients recall difficulty urinating in childhood. That's interesting. This figure, while meaningful, is insignificant relative to the evidence I've accumulated in my own clinical practice, where nearly all IC patients describe having symptoms of pelvic floor muscle dysfunction prior to the onset of the disease. However, my broadened definition of dysfunction includes complaints that develop from a wide variety of stressors, such as constipation, falls, sexual abuse, surgical procedures, and abnormal body mechanics. These stressors can lead to an array of non-urinary symptoms involving the pelvic muscles. I mean, look at you can see all the stuff I highlighted in this, right? I mean, this book is just incredible. I will let you guys, so you can get it on Kindle. You can get it in our store. It's $29.99, worth every penny, every single penny. Listen, this book and our book, IC 101, gold, absolute gold. All righty. What have I lost here? Karen says, please hold up the book again. Breaking Through Chronic Pelvic Pain. Whoops, hold on. By Dr. Jerome Weiss. Kalina says, it's very hard to find physical therapists in her area. You know, honey, you might have to travel. But again, pelvicrehab.com, great place. And look for the ones that are certified. But many others are in the process of being certified and would be helpful too. Suzanne said, have you ever asked your doctor if you are emptying your bladder? I've had IC chronic UTIs. Now I self-cath twice a day and I haven't had a flare for UTI months. Awesome. Jody says, yes, that book gave me the most hope, the Weiss book. The other one is the Interstitial Cystitis Solution. Well, you're missing IC 101, which is our book that we just released last summer. Really helpful. It's the first book that goes through subtyping. Did he, by the way, let's hold on a sec. Okay, so he's got some great patient stories here. So let me just read a couple of these patient stories, okay? Xandra's story. Very recently, 33-year-old Xandra consulted me for the treatment of IC. 10 years prior to her appointment with me, she had developed urinary frequency urgency and pain with voiding. At that time, she also had bladder pain with and without bladder fullness, and periodically she would get the urge to void, but had difficulty doing so and felt like she couldn't completely empty her bladder. Given these symptoms, I was not surprised to hear that she recalled having difficulty voiding as a child. Antibiotics were first prescribed for Xandra, even though infections were not found. Eventually, she saw a urologist or performed a cystoscopy and the installation of a potassium chloride into her bladder. Both of these tests were consistent with IC. The prescribed treatment was dilation of the urethra under local anesthetic, which was extremely painful and caused symptom flares. I had about 100 of those as a kid. Other therapies included Elmeron, Vesicare, amitriptyline, hydroxyzine, 6-DMSO treatments, and finally, installation of bladder cocktails. The installation of the medication into the bladder requires the insertion of catheter into the urethra. This can be very uncomfortable when sensitivity and muscle spasms are present. The last of these treatments, which had given Xandra varying periods of relief, was performed approximately 1 year prior to my evaluation. She told me that catheterizations had almost been unbearably painful, that they had given her occasional bladder infections, and that her bladder had become so irritated she was having difficulty holding the solutions as required. In short, quote, the cure had become as debilitating as the problem it was intended, yet failed to eliminate. However, over the years, there had been some improvement. When Xandra first developed her symptoms, when she was voiding small amounts every 15 minutes, but with the above treatment, that had dropped to every 45 to 60 minutes and twice a night. She rated her current pain as being 4 to 5 on a scale of 10, but said occasionally it reaches 8 to 9. Nonetheless, she had taken no pain medicine. On further questioning, Xandra mentioned having pain in the sit bone area with sitting that for as long as she can remember that referred to the tailbone and the back of the thighs. She never told anyone about this because she thought it had to do with the way I sit and was unrelated to her urinary complaints. She also reported a past history of bilateral Achilles tendonitis and indicated she was presently dealing with low back and neck pain. My external examination revealed extreme sensitivity over the sit bones and perineum for pudendal neuralgia. I also noted bilateral Morton's toe, many trigger points in both hip rotators at their attachments to the hip, trigger points in the quadratus lumborum muscles that help stabilize the pelvic floor, and trigger points in the lower rectus abdominis muscles above the attachment to the pubis. Internally, Xandra had exquisitely tender pudendal nerves with trigger points in both piriformis muscles and the left urinary sphincter muscle. The findings I've just explained all seem to fit the picture of pudendal nerve entrapment as a core problem and not interstitial cystitis. Morton's toe can cause Achilles tendonitis and stress the hip rotator muscles, which can directly compress the pudendal nerve, producing pudendal neuralgia. Also, because the pudendal nerve runs through the Alcock's canal and the sit bones, it can cause pain with sitting, the Xandra reported. Additionally, given that the pudendal nerve innervates the pelvic floor muscles and the external urethral sphincter, when these muscles are dysfunctional, they produce irritability and tissue changes in the bladder. After I performed internal myofascial release to relax her pelvic floor muscles and mobilize the pudendal nerves, Xandra experienced temporary relief. However, because the pudendal nerves were still very tender, I also performed nerve blocks. Here it is important to note that she had more pain in the left buttock with sitting and the left nerve was more painful of the two. It is also important to emphasize that pudendal nerve blocks with anesthetic and cortisone are both diagnostic and therapeutic. That is why I performed them at the time of my intake evaluation. If symptoms resolve for a period after the block, it means the pudendal nerve is causing them. In Xander's case, the pain was sitting and all the urinary symptoms disappeared for 9 hours. At that point, urinary frequency returned, but there was no bladder or urethral pain until the following day. 2 weeks later, the urinary symptoms reappeared, but their intensity had diminished. As for the pain was sitting, it had not returned. All of the above evidence clearly points to pudendal nerve damage as a major source of Xander's, quote, IC symptoms. I can tell you, let's see. Saying he had to go to press. So he said, unfortunately, I cannot delay this book to report on the long-term outcome of her treatment. However, I can tell you that it will include the following: internal and external myofascial relief, extensive physical therapy, biofeedback and evaluation training, correction of the Morton's toe, possible repetition of pudendal nerve blocks, possible injection of the trigger points of the hip rotators to decrease tension in those muscles, possible introduction of stress reduction therapy accompanied by an at-home regimen. By now, you should understand that the bladder is not really to blame for most, if any, of the symptoms associated with urinary symptoms we've been investigating. You should also know that pelvic floor muscles are most likely to lie at the root of the problem, though pudendal nerve is a possibility. And you should be aware that many chronic long-term frequency urgency patients and most IC patients are experiencing central sensitization. As I have emphasized, central sensitization is a systemic disease that poses a significant challenge. The entire gang of perpetrators, including disgruntled elements that keep punching the central nervous system, must be rounded up and rehabilitated to give the traumatized nerves the vacation it needs to heal. Studies indicate that when the vacation is granted and painful input to the central nervous system is interrupted, its functioning reverts to normal. Obviously, the primary objective is to ID the gang leaders, and we have that already narrowed down to 2 contenders, the pelvic floor muscles or the pudendal nerve. However, it is unlikely that the leaders are solely responsible for all the symptoms, yada, yada, yada. I'm telling you right now, this is the book right here. This is the book. Hadar says, do you think that there's a chance that I will feel a sense of fullness that will give permanent? No, honey, I don't believe it's going to be permanent at all. I think we have to find the underlying problem. And as he just said here, he believes that the underlying problem for the great majority of IC patients is muscles and nerves and not the bladder. I would strongly encourage you to get this book. It's excellent. Sue says, what's the name of the website? It's pelvicrehab.com. There you go. All right, guys. Well, listen, I'm going to follow his advice because my left butt cheek is starting to vibrate, which means I need to get up and walk around a little bit. So I do believe that it is time for me to close this down. So let's just do one final call for questions. One final call for questions. I know you're typing. All right, my friends on YouTube, I'm going to say goodbye to you. See you later, Donna. I hope you're doing well. We will talk again soon, I am sure. I am sure.